Good morning, everyone. The time now is 8 o'clock. Members, Minister, you and your team, the professionals, members of the public, stakeholders, those who are joining us online, good morning, and thank you very much for making the time to attend this important meeting. But before we get into the details, I would like us to have a moment of silence so that you can reflect. And the moment starts now. Thank you very much. As we all know that the purpose of today's engagement is for us to deal with the annual report for the years 2024, 2025. We all know how important that is. And once again, we pride ourselves by opening up in terms of interrogating Minister, the works achieved and the challenges they experienced. And this is exactly what we will be dealing with today. And as we proceed, I'm going to explain the format that we will take. But as we all know the drill, we need to know who we are. And we did receive some indications of stakeholders who are here today. I see them. And also we'll be joined sometime today. I don't know whether this morning or whatever time they'll be able to make it. There's also a delegation, a minister from Kenya, the Senate of Kenya. Some members of their Senate are here in the Western Cape. And we're known for being the torch bearers in South Africa. And not just only in South Africa when it comes to health, we're the torch bearers on the continent of Africa. This is the only department that achieve what they achieve in terms of clean audit, in terms of good governance in the whole of Africa. And this is something that has been confirmed with me more than once by the Auditor General. And so Kenya is going to come and have a taste to see how it is done in the Western Cape. But let me start with the formalities, and the formalities are for our introductions. I'm Emery Boyson. I'm the chairperson for this Standing Committee of Health and Wellness, and I'm supported by a strong team, and I'll now allow for the members to introduce themselves as well, and I'll start on my left. Thank you, members. First row.
Good morning, Chair. I'm Member Stevens, and I'm a member of this committee. Thank you.
Good morning, Chairperson, Minister, and the team, and our guest. My name is Rachel van Vogel, and I'm a member of this committee.
You.
Good morning. I'm Thomas Walters. I'm a member of the committee.
Good morning. I'm Benedicte van Minnen, and I'm a member of this committee.
My apologies as the chairperson. I have not had my engagements with the speaker as yet. We are being joined by a new member of the committee. And my apologies, member. And member, I give you the opportunity to introduce yourselves, but during tea or lunch or whenever, we will have our official engagement with you. But welcome to this committee. And as I was bragging here, it is indeed one of those committees where you will feel that your energy will not be spent in vain. You will feel the use of your presence because of the openness of this committee and the department. Over to you. I don't know whether I should call you and abuse my powers to say the new kid on the block. Okay.
Thank you, Chairperson. Good morning, everybody. Good morning, Minister. I'm John Michaels from the NTC. Thank you.
Member Michaels, welcome to this committee officially. And we, as I was saying, we will exchange pleasantries as we go along. Thank you.
Good morning, Chairperson, Minister, all honourable members and departmental officials. My name is Wendy Kaiser-Philander, and I'm a member of this committee.
Thank you. Are there any members online? Looks like we're a full team. We're all in the house. Minister, over to you.
Thank you, Honourable Chair, and to the members of the committee. Good morning. My name is Mireille Wenger, and I'm the Provincial Minister of Health and Wellness.
Good morning, Chairperson, committee members, members from the public. I'm Keith Clutie. I'm the head of department. Thank you.
Morning, Chair, honourable members and members of the public. I'm Sadiq Karim. I'm the Chief of Operations for the department.
Good morning, Chair and honourable members. I'm Glenn Carrick. I'm the Chief Director of Finance.
Morning, Chair, honourable members and members of the public. I am Melvin Moodley. I'm the Chief Operations Officer of Tygerberg Hospital.
Good morning, Chair and members of the legislature. I'm Dr. Tendani Mabuda, Director People Development.
Good morning, Chairperson. Good morning, members and colleagues. I'm Bernadette Aris, and I'm the Chief Director for People Management in the department.
Good morning, Chair and members of the legislature. I'm Anita Pabu, CEO and Chief Director, Red Cross War Memorial Children's Hospital.
Good morning, Chair. Good morning, members, and good morning to the public. I'm Laura Angeletti Dutoit. I'm the Chief Director for Facilities and Infrastructure Management.
Good morning, Chair. Good morning, members of the committee, and also to the members of the public. I'm Vanita Thompson. I'm the Director for Forensic Pathology, but I'm also here representing the Chief Directorate for Emergency Services and Services Support, sorry, Dr. Vanita Arendse.
Good morning, Chairperson, honourable members and members of the public. Hilary Goeieman, Director Service Priorities Coordination.
So good morning, Chair, honourable members and the public. I'm Patty Alkers. I'm standing in for the Chief Director, Metro Health Services.
Good morning, Chair, members of the legislature and the public. I'm Andre Luck from People Development.
Good morning, Chair. Good morning, members. Good morning, public. I'm Peter Smith, People Management Strategy.
Thank you very much to the professionals. I'm now going to allow an opportunity to our stakeholders to also introduce themselves. And I'm starting on my right-hand side. Let me come this way. Just press a mic and then introduce yourselves. And if you can also, if you're representing an NPO or an NGO or a board, just to state that as well, please.
Goeiemôre, ek is Felicity Oktober. Ek is van Witzenberg.
Dankie.
Goeiemôre.
Verskoon my, kan u as u klaar gepraat het? Jy druk om te praat en as jy klaar gepraat het, dan druk jy weer dat die rooi lig afgaan, anders dan gaan die ander nie kan praat nie. Dankie.
Goeiemôre, ek is Elmarie. Ek is van Witzenberg.
Dankie.
Goeiemôre, ek is Monique Jantjies, ek is van Witzenberg.
Goeiemôre, ek is Esmeralda Engelbreg, ek is van Witzenberg.
Dankie. Dankie. My left hand side.
Good morning, everyone. Naomi Batana, Witzenberg Justice Coalition.
Thank you.
Goeiemôre, ek is Caroline, CEO van Witzenberg Justice Coalition.
Goeiemôre, ek is Lenet Alexander van Witzenberg Ceres.
Goeiemôre, ek is Oscar Roy van Witzenberg.
And the two familiar faces there at the back.
Raphael Friedman, Officer of the Minister.
Morning, Chair. Susan Smith, Officer of the Minister.
Thank you.
Good morning, Chair and members of the legislature. My name is Stanley Shuma. I'm from the NCCC.
Thank you. Just, I don't know, it's an announcement or we have these devices as well. Hier's vertaling. Soos ons in Engels praat, is daar iemand wat in Afrikaans vertaal en in Xhosa vertaal. Dan kan iemand net kyk op watter channel dit is vir u, maar Afrikaans is beskikbaar op die copy gadgets. Thank you very much for all the introductions. And as I was saying, we did receive quite a couple of interested stakeholders. So some of them, Doc and HOD, would probably join us as we go along. I'm now going to go into the nitty-gritties. Minister, to you and the HOD. Minister, any opening remarks? And then after you, the HOD. Thank you.
Thank you very much, Chair. This morning we will be presenting our performance and financial information to the committee for the 24-25 day of the work done by the department in the previous financial year. Much of the information will be quite familiar to members of the committee as you have diligently done your oversight over the course of the year in terms of our performance information. I would like to congratulate the department for the work done, and in particular for our 7th consecutive clean audit, which is as a result of a Herculean effort in a department the size of the Department of Health and Wellness. And I think it is really commendable. And with that, we look forward to engagements with the members. Thank you.
Thank you, Minister. HOD.
Thank you, Chairperson. I think today and this specific reflection on this annual report is quite a significant watershed reflection. It is the last year of a 5-year cycle that started in 2020. So it's the last year of that 5-year cycle. Next year, we will be talking about the first year of the new 5-year cycle. And because this is the last year of that 5-year cycle, it's important to understand what this 5-year cycle actually represents, not only in the healthcare system in the Western Cape, but it's the healthcare system in South Africa, it's the healthcare system globally. The healthcare system in South Africa and in the Western Cape and globally has been hit by significant turbulence in the last 5 years. So we are talking about the last of those 5 years. The first thing significantly that hit this healthcare system, all the way from us to globally, was the COVID pandemic that hit as we hit 2020. So for all intents and purposes, whatever the plan was before COVID came, most of those things were thrown completely out of kilter because of COVID for the better part of 2.5 years. So as we're about to come out of COVID, and with all the backlogs that was there, the second big turbulence that hit the healthcare system was not only in Western Cape, South Africa, or global and globally, was a financial austerity hit. You add those two things together, then what we had to navigate over the last 5 years, which is now almost come together in this specific report, is to navigate those two disruptions while people got iller, people had more healthcare needs. So you bring those two things together. It expresses itself from us being very proud that we have our 7th clean audit, but being very mindful that the people that are seeking care from us were significantly impacted in this 5-year period. So when we reflect on this last year of the 5 years, that's the context within which we do it. And I'm just going to use one or two things. The primary healthcare platform has been under significant pressure. You can go to any community health center, any clinic. You will find it busy in most places, but in the places with greatest need, you'll find it overloaded. You go to our emergency medical services, and I mean, the figures here, that we responded to 596,000 incidents during this year, 74,000 calls over the festive seasons, 59,000 calls during the Easter period. And it is everywhere, but in the areas where the need is greatest, the waits are longer. The people that are dependent on the service has a less than satisfactory experience. And you go to forensic pathology, 11,000 cases reflecting the the clinical workload, and the broader societal challenges. So underneath all of this, while we had these big turbulences, is the need got more. Our ability to respond was stretched in certain instances, very, very thin to where we find ourselves. But despite all of those, there are two things that we're very proud of in this period. A, we were able to maintain a clean audit. It's our credibility. And with that, Chairperson, we present ourselves to you like we presented to you ourselves, in humility, at the last quarterly reflection, and we carry that into this session, where we say, and this is the message the Auditor General told us, why we believe in your credibility as an organization was three simple things. When we say to you there's a problem, you say to us, we own up to the problem. We don't run away from it. If there's a challenge, we own up to the challenge. We don't run away from it. When we ask you, what are you going to do about it? You tell us what you can do. We come back and we check. You have done what you say you're going to do. Hence, we trust you. So I think in that spirit, Chairperson, that's what we did in the last quarterly review. We would like to carry that through with yourself. The second thing that we're proud of is that we've been able to work with a wide range of stakeholders to be able to have a collective almost will and a recommitment to take into the new 5-year cycle that actually started in April this year. But the area under reflection, which is up until March, it takes us then into good stead going forward in that way. And the one that we're probably the most proud of is the many hours spent with our colleagues in civil society, to be able to find that place where we hear one another, we listen to one another, and we chart a course together. So thank you, Chairperson.
Thank you, HOD, and thank you, Minister. And just before I give over to the members to engage on the opening remarks, let me just outline how the process will unfold. The members will deal with their mandate in terms of engaging with the officials. And when the members are done and exhausted the whole process, then we will open up to the stakeholders and to the members of the public. And please, when we're going to engage, we need to refer to the page on what the question or comment would be based on. And then also, as we would all have noticed, that the report is divided into parts, into sections. We'll deal with part A, part B, and part D. Part C, Part E, and Part F will be dealt with in SCOPA, as it is the norm and the procedure. So, members of the committee, any comments, questions, input based on the introductory remarks from the Minister as well as the HOD, and now opening up the floor. Going once, Member Venfugo.
Thank you, Chair. I think let me start by congratulating the department for the clean audit. Although I understand the value of clean audits, I think the Minister and HOD is of my view when it comes to clean audits and service delivery. Therefore, because for me, when you say clean audit, there must be alignment with service delivery. And I'm not observing that. But I'm happy that this department is one of the first departments by saying, I think in our previous discussion of meeting, they are looking at strategies, how to align those two. So, yeah, and for that, I appreciate the effort. Thank you, Chair.
Thank you, Member Venfugo. Any other inputs? I don't see any other inputs. I don't know, Minister and HOD, if you want to comment on that.
Just a thank you to Member Venfugo. And maybe just to reiterate, Member Venfugo, what we said at the time. Our conversation with the Auditor General is one, that your finances are in order. We don't find any untoward financial procedures. Your HR information is credible. Your information about your performance is credible. The Auditor General itself says to us what they are trying to do with all the departments that they audit. They want to say, so how does this translate into the lived experience of the citizens? We ourselves have actually said to the Auditor General, that is our interest. A clean audit is not an end in it's not an end in itself. It is a means to an end. So once you have a clean audit, you have the credibility to be able to say, now we want to use the platform of a clean audit to translate it to the experience of people. So when we came to you in the last quarterly report to review our performance, I think all the members that were here would recognize that it's important to start not looking only at the hard data and the targets, is to start listening and telling the story underneath the hard data and the story. So you can have a clean audit in a hospital that functions well and there's nothing wrong with what's happening in the audit, but you can have an experience on a Friday night where there's 125 people in the EC and the ambulance stops and bring 2 or 3 more. Not all of those people can be accommodated in dignified conditions. We're the first ones to acknowledge how do we actually put the strategies in place to make the experience of the person coming into our system dignified under all circumstances, even the most challenging of times. So that is our commitment, Chairperson, and we did reiterate it at the last meeting. Thank you, Member Van Vogel.
Thank you, HOD. Minister, that you wanted to add to that? Thank you, HOD. And now, members, we are now getting into the nitty-gritties. And as I was saying, please indicate your page on which you'd like to engage on. I'm now opening up for section A, part A, and that is from pages 4 until pages 21. And it's not a shame, members, it's not a shame if it ain't broken. It's not a shame if we skip. I'm just saying if it ain't broken, we don't fix it. Member Van Vogel.
Thank you, Chair. On page 4, I think it's the forward of the MEC, the Minister. The Minister in a forward mentioned the challenges when it comes to several public the challenges that the department is facing, including the outbreak of mpox and all those illnesses, and she also mentioned the impact that the US8 and also I think PEPFAR has. So I want to understand from the Minister in the second paragraph where she talks about this, about the termination of the US8 and PEPFAR funding. Can the MEC tell us what was the impact? I think somewhere she mentioned or somewhere I read in terms of the impact, but her view. And do she have data of how many NGOs were affected? I'm not sure, must say. Then I see also on paragraph 4, where she mentioned, where she speak about EMF services in glowing terms. And when we know, I think the HOD sketch situation on how we experience the service on a daily basis. But I want to understand, when we know there are serious challenges with regards to EMS services, are there plans and measures in place to improve functionality of EMS, especially in the rural areas and in red zones within the metro? I will park there, Chair. Thank you.
Thank you, member. I don't see any other hands. We can get a response. Thank you.
Thank you, Chair. And thank you to the Honourable Member for the questions. So in respect of the USAID and PEPFAR funding that was terminated. The effects were primarily in the NGO sector, in the MPO sector. It affected approximately 10 MPOs, and that accounts for about 698 posts that had to be terminated as a result of loss of funding in the MPO sector. I'd also like to mention that it affected our government-to-government agreement with the United States government, which was also terminated as part of this issue. I don't know if colleagues would like to add on. We can answer further questions if needed, but we put together a strategy to pull together the MPO sector, and we looked at how we can gain efficiencies within our system, because a lot of that work has now come into the primary healthcare space. So we looked at multi-month dispensing for clients that are stable on their medication, to be able to get 3 months worth of medication instead of needing to come monthly, take some pressure off the clinics. We've also been working on e-scripting as far as possible to try and drive efficiencies using technology to try and mitigate some of the effects of this funding loss. Yep, covered. Then in respect of EMS, the members asking about future planning. So I think we will certainly be able to come to the committee as we approach the budget deliberations in a few weeks' time, where we will be able to share with you the system strengthening initiatives that we have in respect of all programs, and in particular in respect of EMS.
Thank you, Minister. Member Stevens. Oh, sorry. Okay. HOD.
So just to add to what the Minister said about EMS, one of the things is that the rural challenges for EMS is not quite the same as the metro challenges for EMS. And I'm very glad you asked that we come to you and explain to you what are we going to do in an urban setting, where the biggest challenge is delay of getting to the person because of unsafety of getting access. So there's a whole lot of complex things that we have to do with SAPs and all of those. And we had a discussion at the last quarterly meeting on that. The challenges in rural is that rural is very widely and sparsely spread. So fewer people there are, the more vulnerable EMS deployment is. Because the moment you have a call out to do something, and if that call has to take your ambulance out of an area, the area is left vulnerable in a specific area, and that can happen any time of day or night. So therefore, our strategies are slightly different. And to you, we need to then explain to you the system required to
Sorry, members, I'm getting my groove now. Before I'm going to go to new answers or new questions. Whoever's asked the question, if there are follow-ups, I'll go back for a follow-up, and then I'll go into new questions, if we can agree on that process. Member Stevens.
Thank you, Chair. I want to know, how will the department address the recurring pattern of under expenditure compared to 2023-2024?
What page are you on?
6 and 7.
Page 6 and 7.
And were there any service delivery impacts due to underspend, especially in emergency medical or hospital services? Or are there any plans to relocate savings from under expenditure to high priority health areas? Thank you, Chair.
Thank you, member. Give over to Minister and the HOD.
Thank you very much for the
Sorry, Minister, just to get the flow right. I'm not going to indicate. I'll just look to my right and Minister, you make the call.
Thank you very much, Member, for the question. In terms of the under expenditure, and maybe one of the colleagues can help explain, but as we get towards the end of the year, we have to close the book. So we still have invoices that need to be paid within the 30 days. But because of the time of year and the way the audit is structured, Those invoices are then paid within the 30 days, but happens to fall in the next financial year. So it's not to say that those funds are not allocated or need to be paid against something and not floating around or could be used for something else. They are committed, I think that's the correct word, but they're actually paid a few days later into the next financial year. But just to put it into perspective, because it may seem like a large number, but if you look at it in terms of the enormity of the entire department's budget, the expenditure is less than 1 day's expenditure for this department, just to give you an idea of what a big machine the Department of Health and Wellness is. I don't know if anybody wants to.
Thanks, Shadi.
So just to add, because and that amount of money that you are, and we will talk about the detail on the page, because it's less than 1 day's expenditure. The question that you're asking is how do we deal with under expenditure going forward? Now, because it is that small amount, it's probably very difficult for a department of our size to make that smaller and smaller. Already this past year is smaller than the year before. The big danger of committing payments is that you go over. So the moment you go over, you have to explain unauthorized expenditure and all of those kind of things. So there will always be a saving. The issue is what we need to do is that saving must be as small as possible. And what we have actually as a commitment, again, because of our clean audits, our credibility, none of this money is lost to the health sector. The commitment is when we come to you to the adjustment estimate process and to the budget process, you will always hear Treasury has put the money back that we have not spent into the expenditure for the next year. So in a sense, our expenditure never gets lost. It becomes expenditure almost like from the next day on in every period that we operate. Thank you, Chairperson.
Thank you, Shadi. Member Stephen, any follow-up? Are you okay? Show your hand up, Member Van Vogel. Okay, new questions, yes? Please put on your mic.
Chair, on page 5, I understand that the department has been getting clean audits. That's in the second last paragraph on page 5. I understand that the department has been getting clean audits ever since 2019. And secondly, in respect, and that's really achievement, and in respect to the success of clean audits year after year, I would like to raise the matter of a certain Mr. Serrington regarding the 200 mattresses costing 211,000, which were never delivered. Is the HOD aware, or was he aware? And were these deliveries were these delivered to the Auditor General? Lastly, I checked the annual report for the department under Section C, under the PFS case movement certificate. There were 7 open cases. Did any of these cases include the matter of Mr. Serrington and the 200 undelivered mattresses? Then page 5, the second last paragraph. I am a bit concerned about the accounting officer in their remarks did not mention of the violence prevention unit, as well as the clinic committees and hospital boards. Can we get an understanding of their functionality during the year under review? Chair.
Thank you, Member. Member Van Vogel, your mic.
So just to indicate to Member Van Vogel, if there are cases of suspected fraud, non-delivery, we have a very clear relationship with Provincial Forensic Services. And most of the cases that you're referring to, or the case that you're referring to, is under-investigated by the Provincial Forensic Service. So there is a section, and I don't know on the specific case, Mr. K, if there is specific references to that. But we pride ourselves, and we do that with our provincial forensic services. Any case of whistleblowing, any case of wrongdoing gets the full investigation. We have disciplinary processes. We've worked away most of our disciplinary processes. Anybody finds guilty of misconduct, fraud, we bring cases with SAPs. We do that to the full extent, to the length of the law. So much so, Member Van Vogel, that the reflection from the Provincial Forensic Service with us on their quarterly engagement with us, over this period while we were getting the clean audits, we've been working away against all outstanding disciplinary processes to the point that our people management colleagues actually institute those things very quickly in most of these cases. So, I mean, if there's any specific more detail that you want to go, we can provide that on the request. But in general, that's how we deal with cases. In relation to the Violence Prevention Unit, we have done a stabilization of the Violence Prevention Unit in the period under this annual report. We have established area-based teams across 18 areas across the province. The coordinators are established in the geographic area. So you will find a coordinator in Overberg, you'll find one in West Coast, you'll find one in Garden Route, you'll find one in Cape Winelands. You'll find in each of the 4 substructures coordinators. So the coordinators and the platform has been established. What they do in those instances is to build relationships with all the stakeholders that work in that local geographic areas. So you can imagine people in law enforcement agencies becomes important people to build relationships with. But because we're dealing with violence prevention, the more important relationships for us is actually in the social cluster. It's relationships with education, it's relationship with Department of Social Development, with DCAS. And one of the most important programs that actually was quite well established in that period under review was family strengthening programs, which is done. The Department of the Premier became involved, and DSD, and its parenting programs for parents in difficult situations, and rolling out with DSD that parenting programs meet as many people as possible in an area. Up until March, the reporting period, all of those has been established, and the plans has been in place for a massive expansion in the current financial year. So in the next reporting period, we will be talking about surveying 49,000 children in grade 8 and grade 9 in something called Planet Youth in 123 schools. That all happened in April, May this year, immediately after the closure of the annual cycle. When it comes to clinic committees and hospital boards, the minister has been one of the things that she's taken on. She's got a very, very keen interest because it is her area of responsibility. She's asked us, and what we have established up until March, again, the reporting period, all the functionality of all regulatory and legislative structures, from a clinic committee to a hospital board to a district health council, all of them. And the membership was in one of those cycles that we had to kind of look at where is the terms expiring of people, where should new terms start. A lot of that, we've concluded a full reconciliation until the end of March, the reporting period. A lot of those extension and terms and all of this then, again, subsequent to March, from the 1st of April, has been put into place. All the way to the Provincial Council of AIDS and TB, which is another regulatory structure. And by the minister as well, now having consensus with our civil society partners at Provincial Council, TB and AIDS, that you do not need separate AIDS councils at district level, separate councils, that we are now also in the process of formalizing by the existing district health councils, a representation for TB and HIV. So a lot of things have happened in that area. We're looking forward to reporting on that for you in the new, as I said to you, we're reporting on the last of the 5 years, difficult 5 years. When we start reporting on the first of the next 5 years, we're looking forward even to telling you and sharing you what has happened from the 1st of April all the way to March next year. Thank you, Chairperson.
And if I could just build on that, we did share with the standing committee about 3 months ago the status of the hospital boards across the province, and so I hope that the members of the committee received that information, where it would give you in each instance whether they're duly constituted, dates of expiry of terms, who are the different categories of nominees to the different boards. I'm also happy to say that there were, while there were a few that were not yet constituted, that were in the process of being constituted for various reasons, like the fingerprinting was outstanding and so on. Since then, we have managed to fully constitute a few more boards and multiple clinic committees. So I know the committee, the standing committee, is quite interested in this area, and we'd be very happy to share with the committee in future meetings where we are and where we've come since that last meeting. I think it was in July or so of this year. Thank you.
I acknowledge us receiving that, Minister and HOD. Any follow-ups?
Thank you, HOD and Minister. Yeah, I would love to have because our last visit, Ceres, is it Ceres? There's no hospital board yet, but there's a lot of positive things happening. Board is I'm not sure the HOD asks if anyone wants to on the issue of the matters to ideate this one's part of those investigations of processes that you are dealing with.
Good afternoon, member. Yeah, I've just been in contact with Anthony Small, our Director of Financial Accounting, heads up the compliance. It is not on our radar. So if you could give us details of the facility that it took place, so then we will investigate further. So it was not highlighted via a referral by us to the department, so it hasn't been picked up by our controls, so and it hasn't been escalated to us. That's not an excuse. That's just the fact at the moment. There was no whistleblower, so it didn't come to PFS's attention there. So PFS is not aware of this. If you give us the details, we'll then have our compliance team look into it and assess it. And then from there, we'll take the necessary steps of either dealing with it if it's internally or if it warrants referral to the forensic services. Thank you.
Thank you so much. So I just want clarity. You were aware? No, not at all.
No.
So it's the first word that.
It's the first word that we.
Please do the dialogue through me.
Sorry,
Mr. Chair.
So, ma'am, that is something that you will the committee. All right, thank you. HOD.
We process these things registered. So obviously it would be useful if there's individual cases, and it would not be preferable for us to discuss individual cases in a session like this. If there's, we can give you a summary of all the cases that we're aware of. But if there's a process and people know something, you know, this is how it happens. Whistleblower contact us because somebody else, it enters a process. Thank you, Chairperson.
Thank you, HOD. Member Van Vogel.
Chair, then on page 10, I think page 10 and page 11. But let me start page 10, Red Cross War Memorial Children's Hospital. Given that the department's giving update on the Red Cross Hospital, my only question on the matter is whether the Red Cross Hospital or any other public hospital for that matter is allowed to rent out equipment to private hospital. If so, which policies regulate that lease? And the emphasis is on the policies and regulations. Then on page 11, supply chains management process systems to prevent irregular expenditure. In relation to the matter of the 2019-2020 issue that were never delivered, there is a person, but I think you advise in terms of how we need to deal with the issue. So let me rather than park that question, Chair.
So you're parking the supply chain management
No,
question?
not the Red Cross one.
Okay.
I'm speaking about the
Supply chain, you
supply
park there?
chain thing.
You need a response on Red Cross. Thank you, Shuli.
So the Red Cross issue is a long-standing issue. It's been raised by the committee, the previous member, Michael's
Member
predecessor,
Jacobs, yeah.
and it was raised at the visit at the Red Cross. There's been a full investigation, just to put it clear to the members. There's been a full investigation around the specific issue. The issue under discussion is that the Red Cross Hospital is, in many instances, the last place, the pinnacle place for a child that's critically ill across the entire province, even sometimes beyond the borders of the Western Cape. In that moment, when a child is critically ill, wherever you are, and this hospital happens to be opposite the road from a Red Cross hospital, the private hospital under discussion. It's literally go out the gate. It is probably 10 meters down the line. So literally, if you had to take a Google Maps photo of that place. Here's the Red Cross Village. There is the Rondebosch Medical Clinic. Literally across the road to that hospital. So what happens in that case? That hospital specifically says we have a critically ill child. That is 50 away. This child needs to be on a ventilator. And if the child is not in a ventilator in the next couple of hours, the child in all likelihood will die. That is the situation under which the CEO of the hospital then makes a call. Because in that moment, the CEO says, we do not have, because all our ventilator spaces are taken. So you can't put the child, take them across the road so that we can save the child and put them on a ventilator. What we do have is we have a spare ventilator that at that point is not being used by anybody. In that moment, and this is, I mean, I've been trained as a doctor. In those moments, you make a call, do I save a life? That's the issue that you do at that specific point in time. And in that specific point in time, you say, here's the ventilator, please take it. And it has to be that the CEO gave permission. Nobody else took that decision. It was escalated to the CEO. And the CEO says, please, to save the child, here's the ventilator. That specific ventilator was used to stabilize the child. That ventilator was brought back. So from an asset perspective, there's no loss. A life was saved and the ventilator is there. The question you're asking, which is a really important question, is how does our accounting officer system work? Now, the accounting officer system, which I renew probably once every year, and then I amend it during the course of the year. That accounting officer has not got a specific statement of how do we deal with a situation like this. Now that it's happened, it will enter the accounting officer system. So a standard operating procedure is now needed. This is not something that will happen every week. It will not happen every second week. It probably happens once every 18 months, 12 months, whatever the situation is. And that is that there's now a standard operating procedure within the hospital, but it's not been standardized within the department. And the next port of call for that is that then gets formalized into the accounting officer system. So, Chairperson, that is the actual situation of this thing. Our credibility as an organization, that's what we've investigated. That's our finding. We're putting that to the committee, that's the outcome. If there's any further updates, we can follow it through, but that is the actual official status of that specific issue. Thank you, Chairperson.
Thank you, Shudi. Before we continue, allow me to just interrupt the session. I believe our special guests from Kenya have arrived, and we would like them to come forward and come and sit here to our left-hand side. We've been expecting you, and we are glad that you've arrived. Yes, the first two rows. Members, I'm going to come back to you to continue. I just want to finalize our hospitality as South Africans. I would like our special guest from Kenya, just for the record, so that we can tell our president that indeed you did arrive, and so that we can report back to Kenya that indeed you did arrive. If you can just introduce yourselves first for the record. I'll start at the front, and then we go to the tape, to the seats at the back. And please press the mic.
Thank you very much.
You may sit, you may sit.
My name is Edward Libendi. I work as a legal counsel in the Senate of the Republic of Kenya. Pleasure to be here.
Thank you.
Thank you very much. My name is Charles Ondiki, Deputy Director, Hansard and Audio Services of the Republic of Kenya.
Thank you.
Good morning, and thank you for the time, for allowing us to be here. My name is Elizabeth Mohia. I serve as a Deputy Director in the Legal Services in the Parliament of Kenya.
Thank you.
Good morning. Good morning. I'm Linda Irusa. I serve in the Senate Liaison Office. Thank you very much.
Thank you.
Good morning. I'm Caroline Cheriot. I serve as a legal counsel in the Parliament of Kenya.
Thank you very much. And on behalf of the Standing Committee and the Department of Health and Wellness, we welcome you. And you are indeed in safe hands. You're in a safe space. You're in a healthy space. Thank you very much. And I hope that you guys would enjoy the interactions. And you'll notice that we do it differently, but it is definitely something to take with you after the session. Members, we continue. And Member Van Vogel, before, if it's not a follow-up, and then after you, it will be Member Michael.
Thank you, Chair. HOD, I have, I'm not sure if it's the correct English word, sympathy when it comes to your profession, the way you explain it to me. It's important to save life. I agree with you 100%. My concern is it needs to be formalized, and we need to regulate it, because you are borrowing from the poor to the rich. That's my issue. Now, the working class are suffering because we are borrowing our equipment to the rich. That's my issue, because the hospital is going to charge their patients hundreds of thousands of rands, and is receiving equipment for free from the state. And that's not fair. That's my issue. That's why we are putting emphasis on the fact that it needs to be formalized. We need to regulate it. And it's not, the system was open. I'm happy to hear that there's investigation by saying it's for years. We are doing that for years. So that's a concern.
Yeah. Member Michaels?
Ja, Chairperson, ek wil net by die uitsluitdeel luister, aangesien hy sê dat daar gaat 'n investigation en dan sy explanation in terms of vir die ander emergency. Wat is die scope van die investigation en by wanneer sal die investigation gefinaliseer word? En ja, vir nou is dit belangrik, die scope van die investigation en by when will this be finalized?
Member Kaiser for London?
Chairperson, thank you very much. I'm on page 11. Am I still?
Yeah, we're on page 11, yes.
Thank you very much, Chair. Chair, the second bullet from the top of the page, which refers to the first pediatric palliative care framework that was successfully launched, Chairperson. And it also indicates there that it will improve the palliative care for all children and young people, and especially important in improving the quality of life for children with serious and life-limiting conditions. Chairperson, based on that part that I've read out and that's stated in the annual report, is it possible for the department to kindly expand on what is stated in the report? Thank you, Chair.
Thank you, Member. I give over to my right-hand side.
Thank you very much, Chair. So, first of all, in the context, the Constitution requires that everyone has the right to emergency health care. And that is part of our constitutional responsibility, whether they are in private or public. So from that basis, in addition, the Health Act allows for that in order to achieve the objectives of the Act. And I certainly hope that there's no suggestion that if an item was not in use, was not being used, that a child should die just because they happen to be across the road.
HOD?
So if I can respond to the follow-up question. So firstly, Member Benvogel, the issue is, and my answer was, we agree with you because the practice happened, it should be regularized. There is a standard operating procedure that's been in place since this matter has been investigated. I'll come to the investigation. And the way I explained it, how it gets regularized, it is an SOP or standard operating procedure in the institution. It's important enough for us to regularize it into the accounting officer system that allows for the conditions under which this happens and for the safeguarding of the resources, and that our patients, that is our primary concern that gets our own care, is not negatively affected by it. So that's what the regularization is about. So there is a process, it's already an SOP. There's a process for us to actually do this and place it in the update of the accounting officer system. That's why Mr. Small and all the Mr. Carrick's team is involved for that regularization. So we don't have any problem agreeing to you that the regularization is there. The issue about the specific instances where this is done and whether anybody that from the public accesses care to Red Cross is adversely affected by that decision. Categorically, nobody is adversely affected. The person that, well, the piece of equipment was not in use and nobody else was denied care because that equipment was not for that period of time at the hospital. Our primary concern is to look after the patients that is entrusted into our care. Nobody was denied access to care because this piece of equipment went across the road. Mr. Michaels, the investigation is an internal investigation. It was a team from our head office that went in, spoke to everybody at the place to get the details, and that internal investigation is concluded. I've got the report on it, and therefore these are the outcomes of the report. So thank you very much, Chairperson. I'll go to, do you want to go to?
Thank you very much, Member, for asking the question. This is, I think, a groundbreaking event or policy development in that we now have the first pediatric palliative care framework, which is now launched. And I can't stress how important this is. This is something that very few of us want to think about, but is very desperately needed. And the research shows that many children around the world need palliative care. So that's not only for the end of life care, but also for those that have life-limiting illnesses and diseases. And we're putting a lot of focus on this because it helps to provide our patients and their families with dignity and how to navigate these very difficult circumstances. And I'm very proud of the team that have put this together. If my memory serves me correctly, I think we're one of only 2 places in the world that has a pediatric palliative care framework. So that is very commendable. And I wonder if maybe Dr. Pabu would like to just expand a little bit on what's in the framework.
Sorry, before we do that, something just triggered in my mind for our special guest. The lady who have just responded, it is our Provincial Minister of Health and Wellness. And that is a team on that side. All the doctors and the learned people, and whenever we don't know anything, we run to them. Yes, ma'am.
Thank you. So this palliative care framework for children was developed within the broader framework of the National Palliative Care Framework for adults, which by nature, normally when the frameworks are developed, it focuses primarily on adults. This is also something being driven by our Chief Director, Dr. Arendse, in the province. And so my team worked with Dr. Arendse's team to develop a specific framework for pediatrics. As Minister says, it's not just for end-of-life care. Any child who is diagnosed with a chronic condition that's likely to need medical care and attention for many years would benefit for such a policy. And the main value set of the framework is that it is a multidisciplinary approach. So yes, it might be doctors and others that make the particular diagnosis, but the care of that child would be complex. And so you need inputs from the rest of the multidisciplinary team. So the nurses, the physiotherapists, social workers, occupational therapists, etc. And it essentially is a set of principles by which the multidisciplinary approaches that child and their family who are in that particular condition. Thank you.
Thank you. Is there a follow-up, member? Page 20, you can go. You may go ahead. And whilst we page 4 up until page 21, that's correct. Let me continue to orientate our international guest. Sorry for that, members. These are the policy makers on this side. All the ones who are asking questions and who are interrogating, they are all the members of parliament of this committee. And I'm a good chairperson because of them. You may continue, Member Van Vogel.
Yeah. Chair, mine is on page 20, the organizational organogram. I want to understand the director West Coast. What are the reasons for the vacancy of the director of West Coast? And has it been filled up until today?
Thank you, member. Over to my right, HOD.
Sorry, the answer is simple. Has been filled. Thank you.
So they're going to crop the photo of the newly appointed. All right.
I can say to Member Van Vogel, sometimes filling a director post is a little bit more protracted than in other cases. It was difficult for us to attract appropriate candidates to serve in that post. So therefore, the filling of that post was a little bit more longer than others. But on a second round of interview of adverts, we found an appropriate candidate that has subsequently been appointed.
Thank you. I see the members nodding. Members, we are now going into part B, and that is a bulky part. So I propose that we share that into sections. Can we do from page 24 up until page 69 for the first round? Pages 24 up until pages 69. Any hands? Member Van Minnen.
Thank you very much. My question relates to page 24. I know it's something that is discussed at virtually every standing committee meeting and oversight visit, but it is something that concerns me deeply. The budget austerity measures leading to a lack of nursing and medical officer capacity at most healthcare facilities. At times, the department was unable to render the full package of care. What certainly stands out to me is that very well put together intensive care in the PAL hospital, where there is a limitation on the amount of beds that can be serviced. I also understand that this austerity is really due to budgetary constraints coming down from national level. And you have explained in this section what the department is doing. Could you maybe just highlight for the community, if you don't mind, how the department is actually dealing with these extreme austerity cuts national and how you're maximizing nursing and medical services? Thank you.
Member Walters, then Member Stevens.
Yeah, Chair, perhaps that's vein, and this is going to be probably a type of question that's people coming from me. You mentioned, the way I understand it, it's your family education program, the surveys that you're doing, it's part of your preventative care part of the life cycle intervention also comes from the Premier's strategy. You want the more you have people taking care of their health at home and people educated about it, the less it's how can I say, the less of an impact it has on the health system. Have you done any study? Is there any data? And I know this department is very good with data as to what that saves. Of course, every amount that we save is more money that we can spend on healthcare. I see it as making the rand, the 1 rand go further than it normally will go. Is there any figures for that? It sounds to me like that's part of the strategy. Actually save money by helping. Just quite a nice thing. But have you quite, I think there's appear in an annual report, it's kind of thing that you will quantify over, say, 5 years, 10 years, or 20 years. But I do think that context is important for us to understand what's in front of us. Thanks, Chair.
Member Stevens.
Thank you, Chair. The Western on page 24, they say the Western Cape population is estimated at 7.6 million. How is the growth affect the demand for public health services? And how is the government addressing at its implications from material health services? And what is being implemented in population disease burdens, given the average life expectancy statistics. And under rural health services, why is the Robertson Hospital not been upgraded 72 years? And are there any plans for infrastructure improvement?
Thank you. And in your specific office, can you provide the facilities affected? And can you also present details of other challenges presented rural health service like the hospital where theatres have been closed due to lack of capacity to staff them? Challenges, I think the member just mentioned Robertson Hospital, and also the mental health issues. What is the seriousness of these challenges and how are they being addressed? Then, Chair, on bullet point 8, page 26, can the department give us details of municipalities that are not complying with this responsibility and what reasons are they providing? And then lastly, Chair, on page 27, bullet point 5, can you provide more details about this matter and what is being done to address the challenge? Who is funding this post-graduate education and for what purpose if there are no positions to employ these graduates? Bullet point 5, emergency care, staff who have completed post. Did you find it, Minister? Okay, I will park there. Thank you.
I'm changing my mind. Member Kaiser Philander, you're the last one on the first round.
Thank you very much, Chair. Chairperson, from page 36, in terms of the district health services performance, I know we're looking back, but we're going forward.
Sorry, member.
Yes,
Yeah, page
district health-
36. The members are sexy and the voices are sexy. So please, no sexy voices. Can we raise our voices, please?
Compliments.
Thank you, Chairperson. Chair, as I said, looking back over the year under review and us moving forward, if the department could perhaps just provide us with some insight in terms of targeted interventions or resource reallocations for this current financial year to address the maternal and under 5 mortality in the high burden districts such as the Cape Winelands and the Metro East area. Thank you, Chair.
Thank you. I'll give over to my right-hand side for responses. HOD and Minister, you'll decide. Your microphone, Member Van Vogel.
Oh, sorry.
I'll take a few of those questions and then I will defer to the department.
Thank you.
Let me start with the life course approach. So the Provincial strategic plan for the next 5 years is on a life course approach in which this department has multiple entry points. So we are involved in the educated, healthy and caring society. We also have a role to play in the safety. And so we have entry points within the broader provincial strategic plan, and that's because we take the life course, so from conception basically until a person passes away. So we have significant programs and projects within that and in the person's life course. So suffice to say that prevention is always better than cure. And I'm not sure if any colleagues have the information at hand, but the return on investment in prevention is always significant. You always, for every rand invested in prevention, you get a saving of multiples of that down the line, and that's why investing in children is so important to make sure that they can start well, making sure we invest in adults at the right places so that they can live well, and then moving to the aging population so that the elderly can age well. Now, we are one of the fastest aging provinces in South Africa. Although we have a relatively young population, we are aging, we are beginning to age. That's why we're including aid as part of our strategic. And so we have various programs and projects, and we are developing our strategy for how we can make sure that we are able to, and perhaps some colleagues can talk about some of those interventions for the aging population and the elderly. On Robertson, yes, we do have infrastructure plans. I'll ask colleagues just to expand on it. But also, I think it fell out of this cycle. A brand new emergency centre was built in record time at Robertson Hospital that is now fully operationalised. And you can see a photo of it on page 23. So that is the new Robertson Emergency Centre, which is it's really lovely and it's much needed. And kudos to the team that managed to get that done so quickly. Then I'll hand over to the team to answer around the austerity. If we do have those return on investment figures, growing population and so on, you've got it all for burials and so on.
So thank you, Chairperson. Member van Minnen, the issue that you raise, and so when I made my introductory comments, we don't take it lightly. The fact that we've come out of the 5 years, this is the last of that 5 year. And in this period, that 5-year period was probably, we had the biggest dip in terms of losing staff, coinciding with the fact that it became difficult to fill posts. So we came to the committee a few times previously to say, although we made a decision to fill the posts, then it became very difficult to fill the posts. Unfortunately, nursing and medical staff are vulnerable in a setting for different reasons. In nursing, there is difficulty to fill certain speciality because there's anyway few people around. So the moment you lose one person, it takes a long time to find the replacement because it's a speciality area. But the biggest thing that probably plagues the rural health services, which it comes back to some of the questions that Member Windvogel asked, is that geographically it's difficult to attract people and it becomes difficult and expensive to live there. And it becomes much more attractive to go somewhere else. So the metro is much more attractive in many instances than from somebody that you're trying to attract. So that's almost like a double whammy that you have in certain pockets. So therefore, what we are trying to do when we say becoming with us, but we will come to you, I guess, in the next couple of weeks to start the process about the budget board. And then at least we will tell you about what this 5-year process about. But just to briefly highlight what our strategy is likely to be, is we at the end of this financial year, just about as we got to, well, actually, we just about got ahead of the curve. And that is that we employ more people than actually resigning or leaving the system. Now, for us to maintain that upward trajectory, there's important things that we have to do. The first thing is we must make it easier for us to be able to people. But more importantly, is to make the right decisions, getting the right in the right place. That's probably the more difficult one. Finding and making all of this. But we'll share some more detail as we going forward. Just to remember what this is a question, I shared with Dr. Karim, he's our resident public health specialist. There is a figure that I have in my mind, which says for every, and I know it comes from an American study because it's a dollar, it's dollar. For every dollar spent, you say dollars, it says, so for every child, just saying $1 saved in care. It was actually quite interesting. I think it was your predecessor, the chairperson. We came to one committee meeting here and he had a book. I remember the book. And it says if you invest in these 19 things, you are getting much. And actually, TB is probably treating TB is the most finding TB and treating TB gives you the biggest yield in return. Because then you can understand that a lot of the patients that we have, when they do pick up, they go to hospital, they stay for long in hospital, we just pick up everybody with TB, treat them first time around and heal them. That is a big investment. So I'm just using those two as an example, but nutrition, very importantly. Obviously, you can understand immunizations, and that's part of why we are concerned about immunizations. And when we come to the immunization figures, you will see it, that immunizations, if you do not get every child immunized to its maximum, then you get outbreaks of measles, then you get outbreaks of this. Those are all preventable things. So there's a whole history in the healthcare system that prevention, investment from you can never go wrong. And there's a yield, but the yield varies depending where you intervene on the life course, as the minister said. Then in terms of Member Stevens, I think it's quite important to rest on that point, because population growth is from two factors in the Western Cape, and there's a PERO. I'm sure the members have seen the PERO. So there's a chapter in the PERO that actually speaks to all of these. Quite interestingly, fertility rates are dropping in the Western Cape. So fertility rates are not going up. So people are having fewer and fewer children. It's a national phenomenon. And planning is a very important thing. It's a choice about that. But therefore, aging and the aging population becomes a real concern for us. Hence the strategy on age well strategy. And again, our colleagues, I mean, there's a colleague working with us, Dr. Geffen, and he's going to go to the WHO next Tuesday because he's so excited. He wants to share with him what's happening in the Western Cape, because no other country that he's aware of is actually implementing this age well strategy, which we have consulted with people. So there are details around the age well strategy, but it is actually being benchmarked against what the WHO prescribes as an aging strategy for the country, for the world. And therefore, chronic management, the chronic medical, dealing with chronic diseases are so fascinating. Just the process of aging, is probably the biggest risk factor for somebody getting a chronic disease. So, we've always known about smoking, family history. The process of aging may put you at risk of getting a chronic disease. And because that happens, if we have part of the aging strategy is we must be mindful that we are able to manage not only one single chronic disease, but a group of chronic diseases.
Sorry, HOD, to our guest, we understand and we've been informed that you do have a full program today, but thank you very much for popping in, and we will be in touch electronically. Thank you. Sorry.
Yeah, thank you. So I think one of the things, and I don't do it lightly because although Dr. Karim and Mr. is I'm older than them, I'm entering the aging, therefore even more important.
Maybe dye is on sale.
No dice. But healthy lifestyles, therefore, and it's one of the things that a member Walters asked. So it is not just healthy lifestyles, it's just, okay, let's keep fit and all of that. Actually, it is to prevent us from getting chronic diseases. So therefore, promoting healthy lifestyle, not just for young people, actually, but it is very important as people get into their advanced years, that the active and healthy lifestyle then becomes an important one. And for this, you can follow what Japan has done. A fascinating factor from Japan. You know, we take the population figure and we say, which is the 5-year band that is the most people in your country. In most countries, the 5-year band that is the most people in the country, if it's a third world country, it's either 10 to 15 or 0 to 5, because the pyramid goes like this. In Japan, the band for most people is 70 to 75. So Japan is an aging population. And actually, in 10, 15 years' time, it could be 90, 95. So Japan is leading the world for how we should do that. And one of the big things is healthy lifestyle.
So their pyramid is upside down.
The pyramid is upside down. Yeah. Thank you. Then for Member Windvogel, I think Member Windvogel, I touched on the difficulty in rural health services. And the details to give you about medical officers and where mental health is quite transversal across the rural health services. So as we are a team of managers that work together, the challenges of medical officers is felt literally in every sub-district in rural areas. Mental health challenge is not felt to the same extent everywhere. There are mental challenges that disproportionately exist in places. The driver of mental health challenges are substance misuse and poor socioeconomic conditions. So you can imagine where there's bigger areas of socioeconomic challenges, mental health will be disproportionately higher in those areas. But literally, it expresses itself across the whole rural health service. Municipalities, I'm going to ask Ms. Thompson that will speak to you about the municipalities around portable burials, because she's in forensic pathology services. In COVID, she actually became the expert of burials. But we will ask her just to reflect on the municipalities for that. And then the emergency care assistant, Mrs. Aris, I'm not sure you got to, Ms. Aris has got the detail. And then just the last one, Mrs. Member Philander, maternal neonatal strategy. Will be Ms. Thompson, Mrs. Aris, and then Dr. Thank you, Chairperson.
Thank you very much, JB. Yeah, and Member, thank you very much for that question. I think just to start to indicate that the issue around burial of unclaimed remains is not unique to the Western Cape. This is really a challenge that is being dealt with nationally. And there is actually currently a national ministerial appointed committee that's specifically dealing with matters related to forensic pathology at a national level, because there are quite a few issues, I think, that are impacting the services transversely. But as indicated, we made quite a lot of strides during COVID with the relationships that we did establish with our municipalities. There are, however, some areas still we do challenges with pauper burials. And the issue largely is budget, and the fact that municipalities indicate that they do not have the budget or has not been budgeted specifically to deal with pauper burials pertaining to forensic pathology. I think we've made a lot, as I said, a lot of inroads. We have no challenges in the metro. The City of Cape Town is extremely responsive in taking on that responsibility. So we looked at the figures last week, and I think we had in the metro about 120 cases pending DNA confirmation before we can release those remains, but within a week those remains are released. I think some of the challenging areas, and I don't like to really name and shape, but there are specific areas that we then deal with on a kind of a case-by-case basis with municipalities, but I can share that details that I do have it available, so we can share. But we don't talk about large numbers. I think this is specifically in the rural health services, and it's about 10 cases that's been pending burial.
Thanks. Thank you, Chairperson. So the question relates to the emergency care assistance. So members would recall many years ago, we implemented the occupational dispensation 2007. And this was across for all the health professionals. And the specific dispensation for EMS weren't very well developed. And we, over the years, have provided input to the change of the dispensation, but it has not happened. And we continue to engage. We are now busy also engaging again with our National Health as well as DPSA to look at a different dispensation. But along with that, I think the big reality is we continue to invest in training people. And our staff is very enthusiastic to do that. And so for us, we will continue to train. We also will continue to engage to make sure that the OSD is changed, because it must be amended or another dispensation must be granted for this. At the same time, EMS colleagues are across the world, and because we train so well, they are likely to leave and to be wanted by specifically the countries in the East, and people do go, and it's more money. But for us, it's important that we continue to not only look at salary, continue to invest in training, and to continue to put up the fight to have a different dispensation.
Thank you, Dr. Klisch. On maternal and neonatal child health, we actually have a whole redesign strategy around maternal and neonatal care. Effectively involves changes in designing the service all the way from primary care level all the way through to the tertiary complex hospitals, and everything between. So just for example, we're moving toward MOUs, Unified Obstetric Unit, that have been built and designed decades ago, but they've been designed what we call off-site. In other words, they're too far from a definitive hospital care. And we've begun shifting from off-site maternity birthing units to on-site. In other words, closer to the hospital. I mean, Kali, just one example where it literally is across the railway line. But for the ambulance to get from the maternity, from the MOU to the hospital, takes easily 20, 30 minutes because it's got to cross the railway lines. So our strategy changes involved in redesigning that entire package of service. But within that framework, we've also been focusing, and we've got a whole plan of action for all the areas, not just Cape Winelands, but a whole plan of action around training of our staff, particularly around maternity and neonatal childcare, and how to care better for women who are pregnant and giving birth, but also around equipment, strengthening and dignifying the environment in which women are delivering. So we actually have a whole strategy around maternal and neonatal childcare within the framework of Start Well. Thank you very much.
Allow for follow-ups. Members, please allow me to acknowledge the arrival of stakeholders. We see you, and we appreciate the fact that you've arrived. And you've missed out this morning, but you will have an opportunity when we're going to engage with the members of the public. Follow-ups, members.
Miskien omdat Engels nie my moedertaal is nie, het ek.
Jy mag Xhosa praat.
Het ek seker nou die antwoord gemis, bullet point 5, emergency care assistance. Sy het probeer vir my, maar miskien is ek stadig, so ek wil graag nou mooi verstaan. Because I didn't pick up who are funding this program. And I want to understand what is the purpose if there are no positions to employ these graduates. We are training them, but there's no position, so we are training them for America, for Europe, or wherever. So I want to understand, can you please explain it to me, because I have a small mind, so that I understand this, because you are putting emphasis on, we need to train them, we need. So perhaps I miss your explanation somehow.
Remember, you don't have a small mind, you have a questioning mind. Thank you.
So, Member Winfeld, this is a very important part of where regulatory constraints, impacts on what service needs are. So to train an emergency care assistant is a very important aspect of having a team of people that is a, if we are to look at how we're going to do EMS going into the future, and an emergency care assistant will be a crucial component part. Our regulatory impediment is not allowing us to recognize that category and to place them on the ambulances, right? So that is the part. If you think of forensic pathology services, if we didn't have a forensic pathology officer, our entire forensic pathology service cannot function without the forensic pathology officer. They have struggled for, I don't know how many years, 20 years, to have the forensic pathology officer recognized. So this is all about being forward-looking and saying that you actually need to introduce new categories of staff. We have an established college here, and our college has invested in putting this category of staff together. The regulatory problem is that our processes of going to national to say, here's an important category. We all know they should be recognized. Please give us the regulatory framework to be able to allow us to do that. So that is where the mismatch is. This is a needed category. And to tell you why it's needed is that if everybody else is gobbling up the emergency care assistant, obviously it's needed because everybody believes that this is an important category. The frustration is our regulatory framework to employ them has been slow in accommodating them.
Member, I see you nodding. No more follow-ups on this section. Can we go to part section? Oh, sorry. Oh, sorry. Follow up, my darling. Thank you, co-chair.
Thank you, Chair. Mine, page 51, Chair, District Hospital. I want to understand how is it possible that this program and especially District Hospital achieve all its targets. I ask in relation to everyday challenges in our hospital, like KDH and others where patients sleep on floors for days while waiting for doctors. How I want to align these two with each other. Then, Chair, on page 54, bottom table, also District Hospital. What are the reasons for the over expenditure on District Hospital and which hospital overspend the budget and reasons for? And page 57 table on the output in MSP1 urban response under 30 minutes rate. Chair, can we get proper report on this, on specific when it comes to EMS? It's not possible that the party chief all status on ambulance get reports every day about people who wait for ambulances for hours and they do not. The situation is even worse in rural areas. It was actually by the challenges. So be it can be that all as yeah. Can we get an explanation on that, please? Then my last question. Thinking form with budgets, 58, I think. You were saying we are doing yeah. What are the reasons for overspending on emergency transport? Then on page 68, what is that on children? That's the output indicator there. Then the last question before the last Chair, no, I think I will park there. Thank you, Chair.
Member Kaiser Philander.
Voorsitter, baie dankie. Ek gaan nou Afrikaans praat. bladsy 56. En daarvandaan, voorsitter, member Winvogel het daaraan geraak. Ek oral waar ons in ons gemeenskappe kom, is daar 'n algemene klagte byvoorbeeld van ambulansdienste. Eerstens omdat die ambulans dalk 'n bietjie te lank vat of daar is 'n tekort aan ambulanse. Voorsitter, ek is deeglik bewus van die feit dat ons kyk nou terug die jaar onder under review. Maar dis ook belangrik om te weet, voorsitter, byvoorbeeld, ek weet die Wes-Kaapse regering het onlangs het hulle 2 privaat ambulansdienste byvoorbeeld in die Witzenburg area goedgekeur. So dis 'n vennootskap. So ons sal nou by die volgende review gaan ons kan sien wat die impak is van hierdie vennootskap. Maar dalk net vir ons 'n bietjie insig gee, minister en HOD, oor wat presies is die uitdagings as dit kom by hierdie diens. Hoekom is dit die geval? Ek bedoel, as iemand nou vanoggend sit in Woolsley, voorsitter, en hulle luister na ons, dat hulle net kan insig kry oor hoekom dit so is, dat as die ambulanse dalk nie beskikbaar is nie, wat is die impak? Ons weet wat die impak is, maar wat die redes daarvoor is, asseblief. Dankie, voorsitter.
Member van Minden.
Thank you very much. I don't want to prolong this, but I do want to ask on page 40, I think it's page 44. We start looking at immunization. This is primary healthcare. And I see there is it's still small, but there is a fall off with immunizations. I do understand that this also is in part affected by the whole issue to do with COVID. But as already said by the Honourable Minister, I mean, prevention is always better than cure, particularly when it comes to pediatric epidemics. What steps have been taken by the department to try to increase the coverage of vaccinations? Thank you.
May I respond? Thank you.
Thank you, Chairperson. So member Winvogel, 2 years ago, we were asked by this committee and by Scope why we're not achieving our targets. So the answers were, it's because of the pressures, it is what we need to do. But then the response from Scope was to us, if you know you have pressures, why are you setting the targets that you can't achieve? So what you see is a product of us saying, this is the resources at our disposal. This is what we feasibly can achieve with the resources given to us. So the simple answer of why we're achieving our targets is we calculated this is our resources, this is what we can achieve. Hence, we are achieving the targets for which we have resources for. That is why you will find almost 90% of our targets achieved. It does not mean, and that was what Member van Minden asked us the previous time at that quarterly report. If you had more resources, would you set the target differently? Of course, we would set the target differently. Because if we have more resources, we would be able to invest and do more, and therefore stretch ourselves more in relation to that. So when it comes to district hospitals, it then means that the target we say is, how many people are there? How full is it going to be? That's what we got, and that's the target that we've achieved. Does it mean that all the people get all the care that they need? No, it is what our resources can allow. Hence, when it comes to over expenditure on page 54, we can, on the one hand, tell you the number of institutions that's responsible for that over expenditure, because that's where most of the pressures are felt. And Khayelitsha is definitely one of the places that over expenditure with the district hospital comes from. When it comes to EMS, it's exactly the same thing. We, and again, Member Philander, we are setting the target on the basis of what the resources we have. Therefore, when you come here and you look at our targets that we set for EMS, we achieve them because that is what our resources allow us to achieve. Again, when you come to what is the expenditure, over expenditure for patient transport, there are pressures. And we're all aware of the pressures. Therefore, we are having to take a little bit of resource from somewhere else because we are responding to those pressures. So just to give you a broader understanding of how we got to the place that you, in essence, are seeing achieving all our targets. But you know, the public know, everybody knows they experience pressures in light of it. So if I then go to Member Philander's question then on EMS, specifically around private and the decision we take in Luxembourg, but the broader decision about working with private EMS generally. So there was in COVID, one of the things we learned in COVID is although we had EMS services, remember at the time in COVID when we gave feedback, many of the times is because COVID affects our own staff. We had a drastic drop on the availability of so in this situation, we went into contract under emergency circumstances via business. We maintained some of those relationships. Now, obviously, again, in light of what you said about the Red Cross, we now need to formalize it. And we just attend for formally looking at getting private EMS across all of the areas where it is, including Luxembourg. Because it is then that we then say there are pockets, and we might not use private EMS everywhere, but we might then supplement it in the areas where our pressures are felt more than in others. So that's the logic that we are following. And then maybe just to explain the reasons. If I have to explain the reasons why we have pressure on EMS, there's multiple. So I already explained. In the metro, one of the biggest reasons is safety and the ability to respond. In the rural, it's distance. And our ability to be able to say, because the balance in rural is, if we place more people everywhere, obviously, have to have people must be occupied with the caseload that you can, because again, you can't go back 10 minutes again. That's not nice, but the second, which is patterns of the need for EMS. Those patterns are mainly driven by social factors. It's mainly driven by that, because we can predict to you, and I've said this before, it's a bad thing to say, but that's the reality. If somebody is going to have a heart attack, somebody is going to have asthma attack, the first time I have it is on a weekend at the month of the end of month, because that's the time when we know and where trauma and fights going to be the highest. That's the worst time to come to an EC, because we are overrun by what happens on a month-end weekend. Anybody that's gone to a health service would recognize that. But that happens to be the time when somebody calls for an ambulance. That at that time, there is and that calls is not the same the whole week around, the whole month around. There are certain periods where all of a sudden you have multiple calls at the same time. So we have to bring all of these pieces into consideration. Probably the biggest thing that we have worked out that will free up more ambulance and availability is actually that the ambulance also is the entity that we turn to take somebody from one health facility to another. Because they are require more care and they are ill. So if you all that into consideration, when is it more likely that somebody is ill in our facility that's already now been, but actually they now need to be sent to the next level? When are the most calls? When is the most trauma? Always can come together at the same time. So there's something that we have to work on, but we're working with. This is not done all the time. How do we source these a flex? That is the bit. Is for instance, 3 in hospital. What is the biggest? Because if somebody has got a head injury, they're at the facility, there's no CT scan, they need to call an ambulance to go to hospital, take a CT scan and then come back. If you add a CT scan at that place, actually that frees up more available ambulance time than anything else, than add things. So remember, Philander, we do not take this lightly. This is probably the most important thing in a healthcare system we have to get right. We want to ask everyone to work with us. It's no excuses. It is to embrace, to live with the complexity and help us to find solutions for that. And we do believe that they are starting, and it's the beginning now. And with adding the private into this, we will be able to have local responsiveness in accordance to need that make sure that people are maximally covered for the risk that they need in terms of ambulances. There's another important factor, and that is public transport is just not available in these places. So how many times do our ambulances get called out to take somebody home just because there's an absence of public transport? So all of these factors actually is the solution, not one alone. It's a combination of all of these. We're quite happy to come back to you, as we said to you the last time in that quarterly meeting, to have a little bit more of a detailed deliberation and actually call upon you to assist us. Because you can now see this goes from SAPS, it goes to city law enforcement, it goes to mobility, it goes to the use of alcohol, the availability. It's all of that stuff that impacts on the availability of ambulances when the patient needs it most. Thank you. Sorry, Chairperson. So just Member van Minnen, probably one of the saddest for us as health people. I mean, I'm sure there's many things that, like you just heard, that we're very passionate about emergency medical service. One of these saddest out of COVID is missed vaccination. It's a justice to children, children, people, whatever, to whoever they listen to, and the missing and disinformation that was spread during COVID has given and has made children vulnerable. We have seen what it looks like to have a measles outbreak. You do not want to sit in a measles outbreak. To see small, otherwise healthy young children dying is not something that anybody should be experiencing. There was lots of hard work done to get rid of polio in the world. There's lots of hard work done to make sure to a place where we can say diphtheria is maybe under control. What have we seen in the last 2 or 3 years? Diphtheria outbreaks. I mean, we should have been seeing bird kill in this day and age. And definitely we shouldn't be seeing measles. But that mistrust has translated into people not coming into and bringing the children for vaccination. So what we previously had to do was just to go and reach a mother with her baby and provide access to service. We have to overcome more than that. We have to overcome mistrust to be able to, because people believe now you're coming to poison my child and all this nonsense that's doing rounds. And we feel very strongly because as I admitted, child prevention disease is still there. So again, think very, very clearly and creatively of how do we mobilize people to look after the well-being of children. Like nutrition. I mean, you can see when we spoke to you earlier, for a child to die of malnutrition, it's a sad, sad thing. You see what it does to a healthcare worker when a child comes in and they're dying just because they didn't have food. Those kind of things are the things that really is what we should mobilize the whole of society on. Those things should not happen on our watch in the society that we live. Thank you.
Actually, you just reminded me on a discussion we had when we were dealing with the quarterly reports. And Minister, in your absence, during that period, we came up with various engagements and possibilities. And I want to announce it now to say that because this is the setup that we're looking forward to. We've agreed that we will have in the near future, as a committee and the department, have a discussion like this just to discuss the do's and don'ts, because there are do's and don'ts in the community that we do not understand. We should also, as part of that, so that the community can understand what is the role of a councillor, what is the role of a member of parliament, when can we load on people to take them to hospital in our private vehicles. All of that there's legalities attached to it. There are do's and don'ts. So, Minister, just for your information, that we will have such a meeting where we do not have to discuss why is the budget structured like this, etc. To discuss how can we work together as a community, etc. And then even in that meeting, we will invite our stakeholders to listen to the engagement so that we can leave here knowing why are things happening the way they do. Because what we experience in the communities is different to the law, and is different to the resources available. So we're going to have that engagement, Minister. So going forward, we're just going to have that so that we can all be on the same page. Follow-ups, members, once, twice, thrice. Can we move on to pages 70 to 170? Thank you. Going once, going twice, Member Van Voorgel. Member Van Voorgel, you have already earned your salary.
I cut a lot of questions because the HOD is very good in explaining some of these issues. You were saying page, Chair, just 70 to 107.
From page 70 to 117.
Oh.
Of part B.
Okay. No, Chair, my first question then will be on page 76 of former system that is for people. So why was the target not achieved? Then on page 77, the last paragraph, it's stating that 368 undergraduate students, and out of that, 298 complete their training, and only 156 students graduate with a diploma in nursing, and 142 students with a higher certificate. What is the number of students that failed, and what kind of support is provided to them? And of those that pass, how many have been placed? Then on page 81, Chair, I just want to check what is the number of children that died in the province during the year under review, and what were the causes of the death. Then on page 83, table on top, why is the department overspending on these sub-programs? And what are the reasons for this? Is it poor financial planning or over-reliance on costly service providers? If I can get the understanding. And then on page 83, the second sentence under the table, engineering service. What is the number of posts that were filled? Have they been filled now? Then table on top, I'm going to page 100. National Health Insurance Grant. What is the province overall performance on the NHI grant targets? And why are so many targets not achieved? And then I know the HOD, with the start of this USA issue, was saying we are not so much affected as the department. But I want to understand what is the number of employees that lost their jobs in the result of the funding cuts, and how did the department intervene? And secondly, what was the impact of these cuts when it comes to service delivery? That's now 104. USAID and G2G donor funding. Then lastly, Chair, on page 106, capital investments, what are the reasons for the over expenditure on existing infrastructure assets and rehabilitations and renovations and refurbishments. I will park there. Thank you, Chair.
Thank you, Member. I give over for responses. Thank you.
Thank you very much, Chairperson, and thank you for the questions, Member Van Vogel. So I'm going to ask Mrs. Aris to deal with the first two questions, the question of bursaries on page 76, and also on the questions of page 77, the issues about our nursing college and the output, throughput, and all of this. Just to start off, we are extremely proud of what our nursing college has achieved. And our nursing college is now the first college outside of the university that's now doing the full graduate program, full undergraduate program. And we've had our first cohort of postgraduate specialist nurses graduating. We are extremely proud of what that college does. So I'm going to ask her to give comments firstly on bursaries, which is general, and then the question on page 77 on how many students have failed, what are the support we're giving, and what the placement options are of all of our graduates from nursing. And then after that, I'm going to ask Ms. Thompson to deal with the child deaths, which is your question on page 81. And then I'll come back to after the two of them. The others.
With to the total of us that we allocate. So the VA is 191. It's because at our students like defer, we're not doing the finishing of this year, we defer to next year. So that's part one of the reasons. And the other reason was that one of the HEIs, you see, was not was applied for accreditation program. Did that. Indeed, they went there to like and as a may of the place, but you see, they not lost. Then allocated and utilized it for other courses where we could send and use our people development center for the other to take up the slack and do other training and shorter courses in the meanwhile. Yeah. So that's the one. And then just actual pass rate is between 90 to 97%. So students do get the opportunity to rewrite. That's one of the areas. And then clearly at the nursing college, it's the lecture and manage the support. We are a part of the employee wellness program as well. So if there's anything that the student are not able to handle, they've utilized it quite frequently for and optimally as well. So with regards to the placement options, so we do give preference to holders like in many so preference not get to come with all and Peter outside.
I think the service. I don't have the exact breakdown in terms of numbers, but we can provide that report through. But I can just talk to the trends in terms of what we are seeing. So for our age group under 1, the majority of those deaths, some deaths. So they is In those instances, the majority of those are due to natural causes. You have mental poisonings or drownings, and that's one of the key or core reasons for children in that age group passing away or being admitted to FPS. If we then move into the older category, again, 5 to 9, 9 to 15, one again see the trend. So from 5 to 9, again, accidental deaths, road traffic fatalities, either pedestrian or passengers, again, not being strapped in as an example. So and then again, drownings. And then in our older age category, 15 to 18-year-old, that is where one see the real issue around risk-taking behavior, and the majority of those deaths are homicides. So, and what we've also seen over the last number of years is that gunshot fatalities are now the key vector or the key reason why the child has been admitted into severe fatality. So we can share the details through. Do we have a report available? I just don't have it accessible at the moment. Thank you.
Very much, Monique. Chairperson, just to add, I think the point that Bernie made, the thing about our nurse placement and our programs and our take in is we have a coordinated mechanism with all the nursing, let's call it teaching institutions, UWC, CPUT, UCM, Stellenbosch. And actually our placements is according to our need. So if we plan for students, certain rooms, plan for absorption. So therefore, the ability to absorb the student is much higher because we've planned point or there's one of the really sad things about when you see the child there, and that's the distinction between it. But issue violence, and it just when you look at the data, it starts going out. From 12 to 18, it's 12. You still see accidents and road traffic. Time you get to 18, it's the top one, especially for boys, is homicide, and mainly now because of gunshots in terms of that. So that whole safety just jumps out at you in terms of what sits with that. So I'm going to ask Mr. Kay just to deal with two issues. On page 83, the expenditure trend, what's our expenditure on page 83, and page 106 expenditure. And then I'll come back to myself around NHI and G and all of those.
Okay, and apologies for my tardiness this morning. I misread the time and then got caught on the closed M3, so apologies. Thank you, and good morning to everyone. So, Program 7 is an interesting program because there are a number of disparate elements that come together in the program, and so the comparability is somewhat difficult. So I think the largest one is, if we look at under expenditure, is the health warehouse. Now that arises because we use that as an inventory store for non-pharmaceutical services for our facilities. So there are journals that come in and out from time. The forensic services just had a on some of the pressures in the forensic services. And so because of the program structures that we have, we do have flexibility to allow certain parts and certain sub-programs to overspend. Specific end is around
ability to repeat that we were in place. Then page 6. So 106. So this is actually a very good story. And it reflects in the number of active infrastructure projects that we have. So a couple of years ago, we established a framework agreement for management practice, which made our ability to access service providers that could do capital infrastructure and build considered more. And so we have now got the number of active projects, and we spoke about Robertson as one of those, where we've actually been able to complete a lot more infrastructure. And so we've allowed that because we've got the flexibility again with and the environment rules to allow some places that can go over. We need to deliver, others where we can hold back a little bit, where delivery may not be so crucial, or there may be a saving that we have. And so that explains the movement by and between us. It really is a good thing. And we are seeing the impact of that on the ground and in our facilities, and long may it continue. Thank you.
Thank you very much. President, also just why you on Member Ben Vogel, your main expertise is actually what is called forensic service, and is the observatory forensic pathology service. The reason why this furniture is for very specialized equipment to be brought into that specific area. I'm going to ask Dr. Karim just reflect the G. Mentioned you the act of PEPFAR funding, but he will explain to you exactly about what that one page is that you looked at, which is around G2G on page 104. And I will then come back to grant to just explain to you also what lives in NHI grant. Dr. Karim.
Thanks, Dr. Kluti. So this was quite an exciting program. Actually, we were the only province, sub-national province, that the USAID had ever contracted with directly. Because normally the way the USAID contracts is they contract with national governments. But because of the Western Cape's track record of delivery and the fact that we just spoke about our clean audit and that we're quite careful with our funding resources, we were in fact the only sub-national entity that the USAID had ever contracted with. And so Dr. Kluti and I, for example, have had many visits from people in the US Senate and all sort of high places to understand how the G2G looked in the province. You'll see the objectives and the actual achievements and the focus areas listed on page 104. But in essence, it was around strengthening our HIV, TB programs in particular, but using that as a gateway into strengthening our system of delivery in the province. The Minister mentioned the total number of posts that were cut as a result of it, by the way, was 698. Of the 698, 27 people were impacted directly upon 2G. The milestones that we've achieved are listed there under the actual achievements. I mean, I'll just mention some of them. It's the wellness sites, strengthening our COPC implementation, digital health. That was also quite exciting. And in fact, we've continued our digitization as a mitigating process following the withdrawal of the USAID funding. So we, in fact, strengthening our digitization quite considerably. And in the following year, after this year, we'll probably come back to yourselves and speak a little bit more about our efforts there. Our telehealth also, we instituted that. You'll see there 25,000 client calls were calls. So these are linking people who have HIV or TB back into our services. And we were quite excited, for example, by the e-lockers pilot. We had implemented e-lockers in 10 facilities in the metro. It was quite exciting, actually, because people then, and just down the road, the statistics, for example, were very successful pilot. So people were able to pick up the medication outside of operating hours. Like you would go into a shopping mall, for example, and pick up your delivery out of the box. Exactly the same concept. So people were able to access the medication via an OTP. So it's a very tightly controlled process because of the pharmacy regulation. So each person will get an SMS OTP on their phone to say, this is your PIN code. go to this box at this facility, put in your PIN code, and you will be able to access your medication immediately. Very convenient. And so following the USAID withdrawal of funding, we're looking at how to implement all of these measures, as Minister and Dr. Kluti mentioned, in our services so that we lose the benefits that the G2G program had represented for the province. Thank you.
Chairperson. And then the last question was about the NHI service grant. So just to clarify, this is 36 million and it comes as part of a conditional grant schedule that we get. The main issue here is that that grant helps us with health practitioner contracts. So it's actually contracting people in from the private sector to do work in the public sector. That's actually what the grant is designed for. You'll also see that it's been extended to include providing services in the pressure area of mental health. So because that is what the grant is for, very much what you see as health practitioners and what happened in mental health, you'll see that the numbers of what we thought we're going to get, what we could get, the reasons for the delay or this difference between the two is exactly the same reasons we had with posts generally. Because we've had to then fill these on contract and we had to go through exactly the same processes. So there's been a delay in some of the posts to be able to be filled. But by and large, we've been able to extract out of this grant the service that was intended to be rendered for this. I think it's quite an important point just to indicate to you that within the broader context of conditional grants, there's obviously to discuss the allocation for this year, going into next year. There is this thing that we need to be able to say, how does the conditional grant complement what we do in our system? And we've been talking and working very clearly with our national colleagues in terms of what the grant is for and how that becomes part of our service offering in the way it's rendered. Thank you, Chairperson.
Members, before I give over for follow-ups, just something for us to make some notes, whether it's mental notes or official notes, PO. There's a lot of questions which get asked and we get the answers. And then we sit up straight. So it's an indication that a lot is happening. Like, for instance, the question on Robertson Hospital and whatever. And here we get the answers and it is good news. So, Minister, I think it is something that we need to engage on when we're going to have that whys and why nots and do's and do-nots, because you do issue statements, Minister. But my question is, where can we, because there's a lot of happening behind the scenes. We get it as communities, because we belong to a group, where the statements are getting shared, etc. But then somewhere out there, and then also members, for us to get the opportunities as well to go and, experience, the new changes, etc. But I'm just thinking that we get the answers here, and we do receive the statements, but my French would say, Auntie Sarah does not get the statements, and it is something in her backyard, but she's not aware. And the in the meanwhile happening. So I think members that thing we're actually going to take suggestions as well from the stakeholders, the committee members, board members, members of the public, to also tell us how can these things get to their ears. Thank you. Follow-ups, members. Going once, twice. We're almost there, members. Can we then go to part D? Part D. Then we're gonna, I know my PO is telling me about tea and biscuits and whatever. Can we just do it? And then we can enjoy the tea and biscuits afterwards. And then update from pages 136 and 185. Source commitment. We're now going to hear all the unionists. The unions. I'll sip some water in the meanwhile. I know I caught you guys off guard because normally these things we deal with it after tea and then we come back energized. I'm just thinking of the numbers in front of me in detailed discussion. And as I said, members, if it ain't wrong, you don't have to fix it. So there's nothing wrong in not having a question. I know the questions will come when we're going to go probably to the public time. So members, there's nothing wrong if you do not have answers. 3, 2, 1, members do not have answers or questions. Sorry, Member Stevens. We are at D. D for donkey. Member page one. Or page 153. All right, thank you. Page 153. All right, I'm looking to my right, 153. Member Ben Vogel? That's now your bonus check.
Yeah, Chair. Not allowing us to take a break. But yeah.
We'll break when we gonna go for tea, don't worry.
I'm just worried about Member Walters, Chair.
No, yes, stop smoking.
That's decision.
No.
Chair. Chair, mine is on page 114. Current state of capital assets.
140, yes, ma'am. 140.
11. Where are we one?
You are a few minutes behind them, but we are now pages 136 until
So I that
is the one, but do have recourse.
136, eh?
136 until 185. Don't worry, you do recourse.
Oh, it's fine, Chair.
Privilege.
Okay.
136 until
You part D.
Part D.
Okay. Yeah.
The question with the less questions, the section with the less questions, Part D. Yes.
Yeah,
Brenda.
part.
Sorry.
You allowing me, Chair?
Yes, I'm allowing you.
Okay. Chair, my question then is on page.
We can come back to you, member, don't worry.
No, I do have. I just wanted to check now. I know the HOD ministry is tired. Page 138, SMS overview. If we can look at the 60% African female and the 9% African male, what is it that across all departments, including this one, Africans are underrepresented on SMS posts? What are the plans to increase the representation of Africans on these positions? Then page 139, the people management priorities for 2024-2025. How does the number compare with 2019-2020? And what I want to understand is how many jobs have been cut since 2019. Is the department staff been increasing or decreasing? And my last one, Chair, I want to understand on page 140, under labor relations, how many cases are currently before the bargaining council? And can we get details of perhaps in the writing? Perhaps that can be one of my, and is there any cases that the PI has lost in the Labour Court, Bargaining Council, or even the CCMA? And can we also get these details in writing? I will park there for now, Chair. Thank you.
Thank you, Member Benvoho. I'm looking to my right.
So maybe just to come back to Member Stevens' question, if I understand it correctly, just trying to make sure that the answer the right thing. So that I go on page 153 to, I see vacancies from page 156 onwards. And I see it only 156 to 157. So, Member Stevens, are you comfortable that we address those two pages? Okay, thank you. So just to indicate what's on your page, and you will see vacancy rates that varies, firstly across programs. So just to understand what programs are. So those are the financial programs, and you'll see the highest vacancy rate is the Office of the Minister and the administration. So it's head office functions. That vacancy rate is intentionally higher because we've prioritized service posts. So just to give you a clear indication, we've slowed down administration posts in favor of service posts. So that's why you will see a 16.8 vacancy rate. Then you come to program 6. That is the training function. Similarly, Ms. Ari spoke about the training function. So that's lecturers in our training institutions. And that is the program 3, that's 10%. Everything else is less than 10%. So just give you a sense, in EMS, it's not that we are slowing down the pulling of posts, it's finding people. And as already put forward previously by Mrs. Aris, our EMS basic and advanced and our paramedics especially are so well trained, they are easily absorbed anywhere else. And as he said, the Middle East is a very popular destination for people. All other vacancies rate per program are then less than 10%. So if you take that by salary band, so now we start talking about levels in the organization, you will then see that the vacancy rate, the highest there then is salary band 9 to 12. So that you can see already is now administrative supervisory posts. That is where the biggest vacancy rate lies, but also because of the OSD, that is where our professional categories also lie. So doctors, nurses, all lies in 9 to 12. And we've explained why difficult was to find the people in those areas. Then if you go to the top on the other side, it's then critical occupations on the top of 157. And you'll see here that medical orthodox, I always get this wrong. Orthotist. Okay, so medical orthotist.
You should have asked me, Shudi.
And prosthetist. These are the people that work and produces the medical assistive devices. So these are people that do the artificial limbs, that do things that helps people with disabilities. There is a very difficult, it's a scarce skills of people, and we have to obviously actively look to retain them. So you can see in 3% the cause of this is that specific skills. That is followed by industrial technicians, and that is followed by medical physicists. So these are all specifically niche, highly technical skills, and you can see that they are the highest in terms of vacancy rates. Clinical technologists, and you can even see pharmacists. Pharmacists, the vacancy rate is only 3.6. What does it tell you? That there's an oversupply of food we have. the other side, people, pharmacists get jobs, complain to us jobs, but the pharmacists, therefore, we give pharmacists that are available. The job at the bottom to do with that, and then explanation. Then remember Van Vogel's question, and just this to you, for proud, they can have been in the health department. What we are very glad for is, as an overview, that in the senior management cadre, right? We have currently 6% African female, 9% African male. If you compare that to 19% white male, 13% white male, those two figures have actually systematically over the years started inverting, if we put it that way. White male, female has slowly come down over the years. African male and African female have slowly gone up over the years. Colored male, colored female is more or less stayed the same. And I think Indian male and Indian female is more or less stayed the same. The biggest thing now is in all our interview panels, especially for senior management posts, we are now, in a sense, becoming a place that people want to apply to. So you must imagine that the group of people we're competing with for SMS mayors, African female, in a sense, to start off with a smaller group of professional people, and they have lots of choices. To come. And we are now seeing more people from outside the line and feeling that we want to join this department. Secondly, we're also seeing more African male and female internally developing over the years and getting the skill set to be promoted internally in our department. So it is something that we say to the committee, please continue to watch the figures, please continue to ask us. We are very confident we are going in the right direction in the attraction. There was a page previously when you see how many people left the service in SMS in the last year, how many people joined. If you page, you will see one African male left, but two African males and 2 African females joined. That's just the last 12 months. So there is that movement. When it comes to page 139, I must be honest with you, I didn't quite understand the question because you referred to cuts and what has happened to the percentages. So I'm not sure what the question was.
Page 139. Is it page 139? Page 139, member. Page 139. Your mic.
And the impact of these priorities. The department has staff establishment of 31,402. It's not that page. Come again?
140.
40.
Okay, sorry.
Oh.
Oh, okay.
There's
So no, then I understand it. And you also asked about bargaining chamber often. So we do have 31,000. And given the okay, so yeah. So basically what this bullets is that you see here is what the strategy is. These are the strategic imperatives that we are implementing to try and work with improving our ability to have the right people in our system. So the issue is we concentrate very much, you see a big emphasis on the things that I've just mentioned about people feeling it attractive to come to our organization. So it's really much focusing on people in the organization feeling cared for, feeling a sense of belonging. So you will see employee well-being, occupational health and safety, the culture of the organization, leadership development, training of individuals, all of those things, change management. So it speaks to a very, what would I call it? An emphasis that the people that we have, we want them to feel that they want to stay. And B, the people that's not with us, wanting to join us because they feel cared for and they have a sense of belonging in our organization. So that's quite intentional that is our strategy in relation to that. Then in terms of your question about the bargaining chamber, Labour Court and CCMA, but like you rightfully say, it's probably important for us to actually give that to you in writing, because it's important that we can then talk about specific numbers and explain to you out of that. Mrs. Aris, you want to add anything onto that?
No, I think it's important that we have a session and we provide the information and then can deal with what, because seeing a number might just say the department lost 5, department won 10 cases, but it's important to look at the content and have a full discussion on that. So I prefer that we give a written document.
Thank you. Thank you. Follow-up member. Please put on your mic.
Chair, on the question, 140 people management priorities. I want to understand the staff. Have there been an increase in your staff component or a decrease? That's now since 2020.
So we have a graphic which.
Sorry, Ashwati.
Sorry, Chair.
We're dealing with a specific year. I'm not dictating on how the response should be, but we need to deal with the year in the review.
Question, Chair, if you listen to my question, I want to understand since then, now, where we are, the year under review. Was there an increase or decrease in terms of the staff component of the Department of Health and Wellness?
Okay. All right. Thank you, Ashwati.
During this specific year, we that's where we are. So we've come full circle and we told you the story that this is a 5-year trajectory. So we've come all the way, drop down. We had quite a drop in the last financial year because of that austerity. And we stopped. I'll share with you as what our strategy is for the next 5 years, because that stabilized.
New questions. Member Walters.
Chair, it's perhaps, I'm just going to mention, but I think it's perhaps something for when we get to resolutions as well. I think I'm very satisfied with the explanation in terms of strategically how you place yourself in terms of service you provide, how you deal with austerity measures, how you deal with your staff component. It's measurable, so we can be open about the problems, and so I really appreciate that. But what was said just now as an offhand comment of briefing us about the next 5 years, Chair, if we can perhaps not lose sight of that, because I think it's going to come in under resolutions. And can I also suggest perhaps what we want to consider, you as a chair, we might need to get a briefing whether there's any other fiscal surprises coming from national government further down the line. Otherwise, it upsets the apple cart. I'm sure you'll appreciate it. But can we hold on to that comment by the HOD for when we come to resolutions? Thanks.
You sound like you're having intelligence on something.
No, Chair, I just have, as you said, a very attractive voice, and I needed to have it heard.
Okay. I'm looking to my right.
Thank you, Chair. We'd be delighted to come and share with the committee our thinking for the next 5 years, and we'll share the system strengthening initiatives that are currently underway that will begin in the next financial year, and will tie in nicely also with some of the budget discussions for next financial year. So just before the March budget cycle. I think that might be a good time because you'll then see how everything is linked and how we move from the previous 5 years and into the future and what we're aiming to do in that new period.
Thank you. Member Van Vogel.
Thank you, Chair. My question on 141. Can the department or can we get more details of your 2025-2030 employment equity cycle? What are the targets, especially for the senior top management position? And then on page 146, the organizational realignment projects. I want to understand, perhaps if, let me rephrase it. How many workers from Brackenfell Hospital were reintegrated into the department and how many lost their jobs? In 149, and that's my last question, financial challenges. In respect of the organization structure and available budget, I see that on the current organogram, there is a Directorate of Violence Prevention. Can I check if the violence prevention is a directorate now and what has been its contribution in the daily violence, crime and murders in the province? And what I want to know and understand is what has been the role of the VPU in preventing the daily killings. Yeah, I will pause the Chair.
Thank you, member. Giving over to my right.
Thank you very much, Member Van Vogel. So firstly, Ministers responded to Member Walters. We're happy to brief with the briefing. So Member Van Vogel, on the specific questions that you're asking, the 25-2030 EE cycle is a statutory document that we have to submit, where we, as the department, submit our plan how to address the EE profile of our department. We very much would like to, as part of about the 5 that one is the issues that you got on the transition from Brackengate. What was the name before it became a transitional care facility? Intermediate care facility. We specifically at the time I had this conversation because in the house you asked the questions about it. We went from contract appointments that arose out of money we had for COVID. The contract appointments came to an end because the money for COVID came to an end because COVID came to an end. What we then did is, and everybody that was at Brackengate at the time, as part of the intermediate care facility, COVID facility, were then said, the contract is coming to an end, COVID is coming to an end, the money is coming to an end. What we did is we said, we are starting a Brackengate transitional care facility in the same premises. What we did for that is we had to go and find where's the post going to come from, where's the money going to come from, and then advertise accordingly, and then encourage people that were working at Brackengate COVID facility to apply, like we would do in any other situation. That transition has happened. There are people now working in the Brackengate transitional care facility, which has been employed to do transitional care, which is not COVID intermediate care work. What we've done is we have sent that building custom made for a facility that where as in facility, we're now saying where should we do the transitional care? And one of the recommendations that comes out of that, it makes sense that we consolidate transitional care under the management of the Western Cape Rehab Centre. So the line management of that facility resorts under the Western Cape Rehab Centre, which is on the premises of the Lentegee Hospital premises, the big rehab centre that we have there. And one of the things we're now doing is in the OD is to say what is the appropriate placement of consolidating our transitional care facilities so that we have economies of scale and we do things in the most coordinated way. It's just another example, Member Windvogel, I think that's the point being made by the chairperson and by Member Walters. There's a logic underneath it. And we need to understand and explain that logic to you because transitional care becomes quite an important part of the healthcare provision as we go forward. But that is to give context to what that OD is about, that is on 146. Then on 146, you also raised the issue of the VPU. So let me just clarify to you what the Violence Prevention Unit was intended to be and what it is and what it is not. The Violence Prevention Unit is what the name says. It's a unit to look at the strategies across government and across society to invest in violence prevention. Everything that has been done in relation to violence has been law enforcement to this point. So Violence Prevention Unit is not to substitute the work of what law enforcement is supposed to be about. Law enforcement is about dealing with the day-to-day crime, the day-to-day violence. That is the job of law enforcement agencies. It mainly resorts with the South African Police Service, but it also resorts under the municipalities, under law enforcement, and in the case of the city of Cape Town, a municipal police force. So that is the job of dealing with the day-to-day crime and day-to-day violence. It is very squarely in that entity. We've even gone as far as saying to make that distinction clear, that everybody in law enforcement is involved with reducing violence, so we call it violence reduction, as opposed to preventing violence. Therefore, the unit that is in our department is more aligned to saying, how are we going to prevent violence over a period of time? That's why we're saying it's working more closely with education, with DSD, it's looking at the vulnerable young people, it's looking at parenting skills, and that's why in the next cycle we'll brief you about what the Planet Youth Survey is about, because it's about preventing the things that leads to the daily violence. So I just want to make that very clear that that's the intention. It's never been the intention that the Violence Prevention Unit is a day-to-day crime prevention unit. It's not a crime. I mean, it's not a day-to-day crime reduction and a crime fighting unit. Thank you.
Whilst you're on the floor, HOD, would my understanding be correct, Minister and HOD, that the VPU's inputs will then be crucial during the prof joints engagements? Okay.
If I could also just make the point that violence reduction is more in the immediate term, whereas violence prevention is medium to long term. So what do we have to do now to make sure that we can prevent violence in the future? And many of these programs or projects have a multiple year life cycle, like the Planet Youth, which I hope to be able to brief the committee on in the near future.
Thank you. Any follow-ups, members? So that I can go to the next step. Going thrice, reduced to twice. It's now once. Go on. Members, we have now reached the pinnacle point of our engagement, and reached the point where we don't know what we don't know until we hear from the people outside of the four walls. We have now reached the point where we're going to give over to our community and NPOs and well, sorry. I know the member wants to go for tea and smoke breaks. Let's conclude. Let's conclude, and then we know when we do go for that break, we will then be rested for SCOPA. So what I was busy saying is that we're now going to reach the point where we're going to get inputs as well from our stakeholders. And let me just explain how it's going to work. And for the department, all minister and HOD, we did receive written submissions, but we as a committee have not gone through it as yet. And I want to say to the members and to the stakeholders who have submitted written submissions, we've received it. We will then go through it as a committee, and then whatever answers we need would then be sent to the department and minister, and then we will respond accordingly. Because also, when you get it in writing, you also respond in writing. When you get it orally, you respond orally. Now, members of the public and to our stakeholders, this is how we're going to do it. I'm taking my cue from what has happened in the other departments. Because of the numbers, I'm going to give whoever is going to make an input, you introduce yourself for the record. You say who you're representing, etc. And I'm going to give you 3 minutes to go through your submissions or your comments, and then I will allow for follow-ups due to the time limits so that everyone can get an opportunity. We have now reached that part. We're on my right-hand side. Any? Yes, ma'am, with the white dress. I'll come this side. So don't worry on this side. I'll finish off this side. It is the lady right in front with the white, and then is the lady with the black glasses, and then it's going to be the gentleman at the back. Yes, ma'am, you may start.
Good morning. Thank you for the opportunity. Damaris Kiewicz, Community Liaison Officer at the University of the Western Cape. I think firstly, the hearing is key to a constitutional imperative. Yet only one person has a book. So if government is serious about engagement, I would wonder, is it not necessary for community structures to be able to engage the document besides receiving it electronically? Because receiving it electronically doesn't mean that I have access to it. So I would want for the record that when the department or government decide on the annual report and the annual performance plan, that copies are made available for communities. That's just a comment. Page 20, the Western Cape, the posts that are vacant on the West Coast. I'm not sure whether the members asked it because we thought it starts at 9 o'clock. How long has the post been vacant, and how serious are we about filling the post of the director for the West Coast? And then the chief director for the Metro, what is the consideration about his position? Because we are aware that it's been more than a year that the post is with somebody acting in that position. And then my last question is governance, review of governance. Nowhere in the annual report does it make any mention of health committees and hospital boards. And so, do they exist? Don't they exist? What is the position on the community governance structure as it's linked to the Department of Health? Thank you.
I'd like to apologize for the time miscommunication, and that is definitely something that we take note. And as a chairperson of the committee as well, in terms of the issuing of the books as well, that will be noted and is definitely something, and I'm sure that the department would also take that into heart. The lady at the back.
Hi, my name is Nomaliti Kutwa from Kokoletu Health Forum.
Sorry, please repeat the name.
Nomaliti Kutwa.
Nomaliti.
Yes, Kutwa Kokoletu Health Forum. So I wanted to again to go back to the issue of the ambulance, the EMS, and also because from our community as well, it is a big concern that we are not getting the services of ambulance when the community is in need of it, because of, I understand, maybe the issue is safety And then we understand that as well. But that also sometimes reflects to us as a community that it's something that is being used from the government system to deny us from having ambulances coming to help or to assist our community when they need that. The reason I'm saying that is that we do have clinic committees, as mentioned by the previous speakers, that I think that we want them to be acknowledged, that they are there as clinic committees, maybe as stakeholders from the community. They can come up with solutions in terms of safety from how the ambulance can enter into our communities. We do have structures at the lower level or at the local level, like Neighborhood Watch. There's a lot. We are also health activists. We are well known in our community. They trust us. So we are saying that it is really a concern when it comes to ambulance services in the community of Iguguletu. And the other question I have is that it was mentioned about the e-locker system for medication. I wanted to know also, does it apply to everyone or does it apply to certain people? Are the people aware from the community as well because they go to the facility? How does that process also get that everyone understand how does it work? And then for the last time, it's not a question, but I did like when you raised the chair that we need to come back again and have these platforms where now us as community activists, we understand the role that the government is playing, the role of a ward councillor, and the role that as stakeholders, so that there is not misleading, there is not a misunderstanding. As I come here and say that we are so confused most of the time with how the system of government works when it comes into the community, whereas that the system, again, not that I'm bashing health, but the system when it comes into voting, then everything is done properly. But when it comes now bringing back the services, then there's a big misunderstanding, a big lack, as community activists, that it's unfair. Thank you so much.
Thank you. Back.
Morning, Crispian Holbrook, District 6 Clinic Cluster Health Committee, just recently reappointed. Good morning, everybody, and thank you. It's wonderful to see so many representatives from the department here. First things first, there was a mention about staffing. Can I please add to that and suggest that if we know that of a particular and important facility is retiring, that surely the post can be advertised so there's a continuity in replacing that person and not a hiatus. And this goes for many, many departments, responsible people, that if the HR department knows that they are retiring, surely you can actually start replacing those people and handing over. That's one thing. Can I also please request, as far as human resources is concerned, that, and Ms. Kivitz kindly has brought up the issue of health. Why are we excluded from so much as far as being part of the clinic facility system? And by that I mean, why are we not included in the HR system that we can actually have access to certain things? There's a lot of, when I say lockouts, we've got responsibilities. We get pushed from pillar to post when it comes to actually doing something, whether it's something as simple as typing up minutes, to a lot of other responsibilities. And it seems to fall upon what I call HR, because everything has got an access issue, which is HR related. And then just to pick up on another issue is that in trying to actually get answers of questions that we have to bring up of the ideal clinics assessments, it seems that we are dealing with a headless chicken here. So Chair, I'm going to request that we do have an interaction and an engagement with your portfolio committee, with representatives who are either appointed members of current health committees, past members, and also the old health forum people, because there's a hell of a lot of frustration. Thank you so much.
Thank you. Can I come to my left? I'll start right at the front as you guys are sitting. Thank you.
Thank you very much. My name is Linda. My name is Pete. I'm from the Locomotion but I'm running the pupils for community services, standing firm with our communities. Chair, I'm use this name says I'm so very disappointed to be made for today because I think last year we were here, all of us speaking regarding the health issues and so on. But in my ward or in my area, I never see anything so was positive. For example, I want to getting more understanding between Western Cape government and the City of Cape Town, how to works those two. The reason why I want to say this, there is an issue of sewer running day by day. When I was listening, one of the speakers says the issue of health, particular the young people or the children, are so concerned. Another question I want to understand. Last year, I was asking there is a who work home-based care, they're running day by day with the doctor. But these people are working for 5 years, for 10 years, no development in terms of the skills or in terms of, I'm not saying that the knowledge, but in terms of the capacity building, where, for example, I can see in day hospital, other hospital like Karl Bremer and Tigerberg. For last chair, in terms of the clinic, so-called that is under a City of Cape Town, there is a district or there is a day hospital. How to work those to clinic hospital? Because when I'm going to clinic, says I'm old, I must go to day hospital. But when I'm going day hospital, it says you're not supposed to parachute from Gryfontein to Karl Bremer or Tigerberg. But I'm very serious in terms of the sickness. I must be stabbed or I must be shot. But I'm not sure why the policies or the code of conduct or what. I want to get that clear because I believe that you are living in a democratic country where I'm feeling to attend. I must go to attend. The issue of day hospital and then is still concerned the minister. And I'm still believe that the Committee of Health, particular for the Western government, it can visit Fontaine to also listen the grievance of unit in terms of the health, because really the health is very important. I think I believe like our now was what is saying, and in terms of the safety, Chief Chair, a safety not always must prioritize with a member of communities. There is a court of law or there is a law is supposed to implement in terms of the law enforcement, in terms of the police. Why the police is not look after our communities in terms of the crime and so on. Like, for example, to store CCTV cameras like here in CBD, ProPulse, Noble Watch, and so on. So that's why it says sometimes the government, they want to run the situation is supposed for the follow, Chair. But thank you for your time.
Thank you. The gentleman next to you.
Greetings, everyone. My name is Neto Sifumba. I am the member of.
Sorry, can you repeat your name? We're writing down.
Okay,
so when we
okay.
respond.
My name is Neto Sifumba. I am a member of a Guguletu Health Forum, and I'm the chairperson of the Health Committee at the Guguletu CAC. For me, I want to put emphasis on the matter of ambulances in our community, because you know it's really frustrating for us, because as we all know that ambulances, they must first go to the SAPs and then wait for an escort, while in the meantime people are dying or patients are dying, you know. My colleague, they mentioned about the structures that we have in our communities. Now, my question is just to add on what she was saying. When are you guys, or how can't you guys recognize them and try to support them in a matter of we have these structures that are there, like neighborhood watches, they are there, the area committees and the street committees, they are there and they are willing to assist, you know, but it's just a matter of being supported by the government and ensuring that they have the necessary resources that are needed, or they have programs that are there to help support them into making sure that to the safety of the ambulances. Yeah, and then you spoke about the nursing colleges that give giving full nursing graduates. You know, in our clinics, we have a crowding of patients, and yet we are always short-staffed. But now here you are talking about nursing colleges that have graduates. You know, how I don't understand. I really, but what is happening with those nurses? How can we have a shortage, and that there are people who are there who can do the job, and then they are needed in our facilities, and that but they are not there. And then for the CHWs, and my colleague has also said, for CHWs, when are you going to also recognize them and maybe also try to I don't know how to put this in English, but nabo bangene kwezi positions that are needed in our facilities, instead of always working on the ground and doing that. You know, it's frustrating, really. But I think I have just there to say thank you.
CHWs to be integrated,
Yeah,
you know,
yeah.
for permanency.
Thank you.
Can I go to the second row?
My name is Noe from Guguletu Health Committee in Guguletu Basic. Good morning, everyone.
Morning.
I want to elaborate more what my chairperson from Guguletu CAC has said about issue of CHWs. Yeah, it's been a long time when we're speaking about the struggle of CHW. They were promised long time ago, even to be deployed in hospital. I always respect them because I've got testimonies, even when my mother passed on, died of a cancer, where they assist. They are doing a lot for a community. Those people really need their struggle to put into consideration. There's no way. They are working more than even the professional nurses, HWs. And they are the ones that are robbed, that we must make sure as a community that they are safe when they are walking up and down and service the community. I think by coming here every time, listening to these nice reports, and then at the end of the day, there is no implementation. And another thing, man, I don't want to. Norma French is no longer MEC or whatever of health. But shame we are feeling that she's not there. I don't know even who is the MEC today that can interact, direct. You know, as health committees, they said we are a governing structure. But we are a governing structure And we have seen as fire brigades when there's problem. Even talking about recognition of e-health committees in the clinic, there's no recognition, proper recognition of, there's policies that really need, that are talking about us, but we're not part of doing those policies. As we said, nothing about us without us, but why there are policies that speak about us and at the end of the day, they are not speaking what we suppose we operational do in our CAC. And I want to, okay, issue of malnutrition. I think we were interacting with you in terms, and you were understanding the issue of poverty as a person that we were linked with Mitchell's plain substructure. Those issues are still there. And you were doing very well when we identify some communities that really need that service of malnutrition. Because when we talk about issues of social determinants of health, we are talking about environment. We check what is happening in the clinic and check and do the observation in those homes where they need help before those children died. We cannot every time talk about services that are there. Meanwhile, these things are not happening practical. I want to come to the issue of ambulances because the issue we're going to seem as repeating one thing. I was listening when I was entering the door. I don't know if it's a door. Yeah. When I was entering issue of private ambulances, I also want to check and put in consideration the issue of private ambulances. They were doing very well, as you said, Mr. Kitlud, in the time of COVID. But now, what are the stumbling blocks? Why don't you let those people, if the workload is too much for ambulances, why don't you let them come in and be in the party, so that at the end of the day, what our aim is services that must be rendered to a community. Please, let us not talk about these things and then we don't deliver. I think the last accountability, man, you know, where are we as a community in all these reports that you are giving us? And interaction with us as stakeholders. Yes, we are invited here. Where are those, what was called, those meetings that were called where we interact direct with MEC? Now, I don't think the MEC of today is like sitting in other planet and then we are in the lower planet. We used to interact with these people so that they can know exactly what is the struggle of a community in terms of delivering health in our community. Those ITP, those what, those, why don't you sit down and do introspection and check what was working before? Painful. You were there. Yes, we were complaining, nagging that time, but we must wait and do checking what was working that time that we can still use now. An issue of NHI, we're talking about the issue, where are we? Accountability, because you don't even come and educate a community. Yes, I'm not even impressed about signing into NHI. Meanwhile, we are left behind. We are not empowered. We are not trained. There are levels of these things. We are not even the structure that is going. We don't know those things as a community. That there's going to be a committee, the minister's going to appoint and whatever. Tina, we think when we talk about NHI, I'm just going to march from my house and go to private hospital in Claremont. I don't even know if there's a requirement. There's something that you must show before you know. So please, man, just reach us in these things. When we talk about accountability of EU, because we put you in those seats, we don't want to remind you every time. And if we said we can do a register and check how many organizations, how many parties are here, how many members in the portfolio, and how many are represented today.
Mama Siyabonga Sabuel.
Are you cutting me out?
Wait,
Let me check if I'm finished.
iminyaka yakho mabe nsithi ndizawuphinda ndenze umzekelo
You're going to
wesibini.
come back to me.
Yes.
Okay, sure. I've got a list.
The lady next to you.
Oh.
Yes, thank you, Chairperson Naomi from the Witzenberg Justice Coalition from Witzenberg. And I think that is and I want to echo what the comrade Mama have said next to me. When it comes to health in rural communities or in our communities, you cannot put time against it because there's a lot of issues. If you specifically look about this report, and when I came in, I was told that you need to refer to this report. This report doesn't speak to what is happening on the ground. It definitely doesn't speak. It speaks with those with the jackets and the ties. It speaks to those with the PhD degrees. It speaks to the ones. It doesn't speak to us. It doesn't speak to the comrade next to me. It doesn't speak to Tilburg that is still waiting for the ambulance gate to open. We've been here, and I think it's important when it comes to the communities. The Health Planning Committee cannot give us time. We've been here on the 18th of June. Witzenberg has managed to get 800 Rand to get here. 18th of June. I've said there on that side. Today, our transport was 3,800 Rand. This is how important it was for us. The same, we've asked the minister, please just come to Witzenberg. Dr. Keith Kloete exactly knows the issues in Witzenberg. There was a time, Dr. Keith Kloete also said the reason why the hospital and the clinics are so overcrowded in Witzenberg is because mense drink te veel. Vandag, Dr. Kloete, is ons allemaal nugter. Ons is allemaal nugter vandag. So the issue is, from June until recently, it was nog steeds 4 ambulances. We still had 4 ambulances. The minister was nog nooit daar nie. The irony of this book, let me take you, ek gaan ook nou slim klink. Let me take you to part D. Nou klink ek slim. Let me take you to part D. Sister Dumpies. Dis Paulo Crossal in Nduli. Die sister Dr. Kloete was al 2 keer aangeval. Wat het die departement gedoen? Eventually was het community healthcare workers wat na haar omgesien het. The irony of this picture is hierdie baba daar 'n ambulans nodig het. Is die ambulans op die berg. Let me take you back. Ek gaan nog slimmer klink. Ek klink ook nou diep.
Klim maar baby, klim.
Part F. Net 'n paar weke nadat die minister in Ceres toe maak hulle hierdie burn state of the art oop. Minister, I can assure you, we've got phone calls from the community. They wanted to know how many money was spent on this. A teacher asked me, Naomi, we are grateful for this. Is there going to be an ambulance to bring the child from the shack who was burned? Ek weet nie. Daar het honorable member Philander gevra as hy nou moet Woolsley toe gaan. Very simple question, Dr. Kloete. As ons nou moet Woolsley toe gaan, what answer do we give people now? Dr. Kloete laat klink alles and maybe ons met die rooipips net 'n bietjie stadig. I'm not entirely sure. I cannot seem to connect the dots. What is happening here? And what is happening on the ground, I cannot seem to connect the dots. We've asked the minister, if we are the wrong people, like Witzenberg, daar is Philander en Windvogel. Witzenberg is 'n ryk dorpie. We don't need to sit here and beg Dr. Kloete for money for ambulances. Kom na die boere toe. All of a sudden in the newspaper, there's something about private partners. Wie is die private partners? Wie is dit? Ons weet nou nog nie wie dit is nie. 12 October. A diabetic person, after started bleeding for 4 hours, waited for the ambulance. Wat moet ons vir mense sê, Chairperson? Sê net vir ons as ons nou weer uitgaan, and we need to design a pamphlet for Witzenberg. Wat moet ons vir mense sê? Dr. Kloete praat en dit vir alles 'n antwoord, en dis baie gevaarlik. So maar eerlik wees, familie. But about patents and stuff and about tender processes. The department has most data. I don't want to know about tender processes. I want to know what is the specification in the tender processes. If you tell me the patent in Witzenberg, dat daar steeds 2 ambulances nodig, sê dit vir ons. Sê vir ons the tender for Witzenberg because of the patent, because we can pick it up here and pick it up there. You only need the capacity is 2 ambulances. Then we can tell the community, listen, die slim mense het die studies gedoen. Daar's patents en daar's data en hulle gebruik hierdie slim tale. Ons gaan net 2 kry. Then we can go. Op die stadium praat die departement en we moet honest officials. We must honest. Miskien is nie een nie, daar is nie niemand om af nie. Kom met maar gesê dit. Ons kon net gehoes het, daar was nog maar vrees in ons areas in. Ons wat nou aan nie. Dis baie heel 3,800 is not 380 rand. Is 3,800 rand wat ons gekom het om te kom sê daar's probleme. Almal in die kamer weet, Dr. Kloete nou sê dit as wel. Hulle klink die ding van Rooi Kruis in die ander hospitaal. Ja, ons moet mense help. Dit was dieselfde departement toe Witzenberg, toe Ceres Hospitaal nie beddens gehad het nie. And people in the department knows that. We didn't have beds. Dis dieselfde departement toe die gemeenskapslede 'n middel neem vir 'n ouma wat gesit en slaap het. It was the same department that said no. They can't take a mattress. Eventually we had to ask the police. Please convince the Department of Health to take this mattress. Nou laat klink sommer nou weer middelklas reg. As ons vir die een doen, dan moet ons vir die een ook doen. Al wat ek net weet, ek weet nie van die res nie. Die vrou buggy. Ek is confused soos ek is. Was all due respect, I'm confused. Ek wil weet, dan nie nie. As daar nie is met ons, nog beklei nie, dan gaan nie kom nie, ons ander maniere kry. Thank you, Chairperson.
Thank you, members, for the inputs. I'll now give over for responses. I'm giving over to my right. Thank you.
So let me start with Ms. Patana, your last comments. And I'll go back to the colleagues from Google Edu, I'll go back to Nosi, I'll back to the 3 colleagues from Google Edu, and I'll work my way back to the other comments. So what I'm hearing from you, which is a call for honesty, involve people, and be fair. Is that fair to say that those are the 3 things you're calling for? If that's the 3 things you're calling for, we got a journey to walk together, because that is our commitment. Honesty, involve people, and be fair. So I give you the commitment that that is the basis from which our organization operates. To come back to your issue, what tell people then in terms of fairness? We will have the engagement with you and all community structures to say, this is what we have, this is what we can put down. Not run around in the rings, be honest, be straight, and put it that way. The second thing, though, is honesty. Honesty from where I'm sitting is being able to call a thing for what it is and being able to talk directly. Now, for honesty to happen, we have to create places where people feel psychologically safe to be open to speak. I've said it, and Nosi knows I've asked it for her. I'm saying, you know, the same, Naomi. The people that are working in the front line at these places are doing the best that they can do with what they got. If they are doing things that is not the right thing, it is our responsibility to own up to it and to fix it. But is to reach out a hand so that people can be safe and create an environment where they can sit down and they can sit in the same place and they can talk to one another and reach those local commitments. And I'll come back to the colleague from Gooks because that's what I'm hearing the colleague is saying. Community structures are willing. You guys wouldn't have traveled all this way. You wouldn't have made the effort and stay in the game, Nosi, for all these years if you were not committed and carry the community at heart. That is what we have to acknowledge. And we have the greatest appreciation for all of you to do that. And therefore, what to tell the people in Witzenberg? That's a very important question. And it is important. We must be clear about what is the specifications for the private sector, ambulance, Nosi, for both Witzenberg and for Google Edu. How are we going to go about it? When will it happen? And who is actually all of those? So I take your points, Naomi, very seriously. And as a department, we will respond accordingly. I think Sadiq indicated to you what our process is, and we will take it up in that way. I think it's. I think the bigger issue here is that, and I was gonna link that to Nosi's point, because Nosi, your point, if I work my way back from Naomi's comments, your last point was about NHI, right? And you made the point, do you walk to Claremont Private Hospital and go knock on the door and do you get that? So it is important that we have the right platforms to have a clear understanding. When we have a policy intent and when we have an implementation plan of actually how services are organized. So very much so, we have in this province we've had interactions and engagement with private sector. So it is important that we sit with the private sector. You might have also picked up in the media that there are court cases against the NHI Act. So NHI, in its intent, and I think even the National Department and the President, everybody has said it, it's not going to be implemented for at least the next 10 to 14 years. It is a concept. To implement it, you have to do the building blocks to work to it. One of the problems is there's not been an engagement with people in local communities to say, what does that 14-year path look like? And it's very difficult to have a path with somebody 14 years if their need is tomorrow afternoon. And Naomi, I think that's the point that you always make. The urgency is, what do we do with the next person that needs the ambulance? So we understand the urgency, we understand, and therefore the NHI is not a solution for tomorrow or the day after, but there needs to be a conversation. How will the public and private resources come together to give a better service to people in an area? That brings me to the hospital and clinic committees. So there is the question, and there's quite a few questions that came out. What is the recognition of local community structures? That includes Witzenberg Justice Coalition. So it's all interested local community structures. What is that engagement? And engagement has to be at the local level. It must be. It cannot be extracted from that. And Nosi, you've been to a few of those structures where we have a provincial meeting. But a provincial meeting can't solve the Google problem, because the Google problem needs a Google to local solution. Tilbach needs a local Tilbach solution. And the same goes all the way to Laingsburg and to be fair to everyone, we need to get to that point. So I'm not sure, maybe I should, can I say what we're going to do in January, or is that okay? Yeah. So the intention is, and also I mentioned it to you when we were last in Lentegia. The intention is what the minister has done. The minister has asked us, what is currently the limitations with the clinic committee legislation? So there was a question from the committee. What's the status of the clinic committees? Where are they? Where's the hospital board? You heard Christian saying that he's just recently been reappointed. But there's other things about the functioning of the committees where people have lots of frustrations. So it's about what are the powers and functions? How do people do what they do? So the ministers actually asked us to say, let's have a review of what we want the committees to do, and go and consult with people what that should be. So our current planning is, Susan, that probably around about January, February, we will be engaging on the roadshow, like Normal Friends did the last time, you remember, is to go to geographic areas and speak to people locally to get that input on. We've had a committee that has looked at what is the functionality, what are people saying, and how could we possibly open and consult. So I'm just saying to you, there is an intention before the end of this financial year to engage, to understand how these structures come together. You can add to.
And Chair, through you, I'd like to add on the clinic committees and hospital facility boards. We've also done a survey as our first step to try and understand what are some of the things that are working and what are some of the things that are not working. So as I came in to this role, we had a look at all those legislative requirements in respect of hospital boards and clinic committees. Just to say that the annual report before us is a statutory document which has specific requirements on what we report. And that is why you won't find specifics around clinic committees and hospital facility boards in this book. But that by no means that it is not integral and important to the department's work. You will all know that we've spent a lot of time and energy in making sure that the committees and boards are operating and functional. Most of you that are representing clinic committees would have received a letter from me in the appointment process and also thanking all those representatives for the work that you do to volunteer for our committees and boards. You are such an important part, and that's why at the bottom of the letter you will have seen that logo of the health heroes, because that is how I view our clinic committees and hospital facility boards as health heroes. That is our interaction and our engagement point with local communities in how we operate. So we are looking at changing the legislative environment in consultation, but I'm sure as the members are aware, legislative changes are a lengthy process, and we do want to make sure that we get it right. So we look forward to engaging with all of you in the making of this process in the next quarter. Thank you.
That then brings me to quite a few of the colleagues have said. So number one, there's three big things that people have raised that has been repeated across. The first one is EMS. So that is, you heard the EMS from Witzenberg to Googs to everyone. And again, I think the point is we need to have those honest, frank conversations about what we can do, what the process is, what will it look like for an EMS response in the local area, including EFAR, CFAR, all of those conversations, so that we have a coherent local response and you understand what the roadmap is going forward. It is important, I think, Dorsey, the point that you make is EMS then becomes part of the local health response. It's quite an interesting thing that we have to then say, what is the role of a local health committee? Is it only for the committee, for the clinic, or is it for the geographic distribution of services in that area? Because I think I heard that from you. Because that then comes out to what is the role. Because the second thing that you've all indicated after EMS is community structures are willing to participate. But then it is about defining what the span and scope of a community structure is. So Christian, it is very difficult to say that in terms of roles and functions, and Ms. Kivitz and see Mr. Lindors, this is the history of the structures that was there. I always remember Ms. Kivitz was saying, what was it? Nose in making a distinction what is old and it's a difficult thing, and we need to have that conversation because oversight has got a specific role, Chairperson. And and that's why I appreciate this thing about clarifying roles and the responsible functions. So I really like what the community members are saying. What's the role of a local ward councillor? What is oversight? What is the clinic committee? Where is this? And to be fair to all of you, we need to clarify all of those things and make it very clear. So after EMS, the local communities being involved, the third big thing that came out is community health workers. So let me just unambiguously say to you from a community health worker perspective, a community health worker in the national dispensation and everywhere in the world is exactly what the term says, community health worker. The day we put a community health worker in a health facility, disconnect the community health worker from their core purpose, which is to be the person that is actually door to door. Now, to be fit to the community health workers, and that's a gentleman, that's a point you make, what is their prospects? What is their remuneration? How do we look after their safety? That's important questions. But a community health worker, by and large, all of us need to have that conversation. Their job is to link people in homes to the health system. They need recognition, they need support, they need all of those. And we have met with NPOs recently, and we do need to walk that journey as part of that local conversation. That does bring me back, I think, the point you made. We are graduating people from nursing colleges. Where do they go? I can tell you an interesting story. I went to Klein Vleis. It's interview local Vleis. He would understand. I would go to you with well and have because years just in the from to his finger the point. Google, we need to see the link between CHC and own clinic. Because Google into CHC can only grow and take so many people. But as a gentleman says from Kraaifontein, if the city clinics are only doing partial of the work, more and more work goes to these, let's call it employees, they get overcrowded. And adding staff into an overcrowded place is not necessarily going to solve the problem. So that's where we need to have this conversation. Because the whole thing, and you're right, what's the future of a two-deal system? It have facilities, province facilities in the areas we've actually dispensed with that. So we need to come back and have a conversation. As a department, we are very committed to actually have one authority. And even agree with us to on in terms of and conversation of things, because then one of the facilities in the geographic area, how you bring those things together. If I can then go to the specifics that some other people, right? The issue about safety and law enforcement, I think that issue is, we know that those are very unsafe areas. Ourselves, we try to explain to the members of the committee that the Violence Prevention Unit is not there to stop the crime. But we have to work with our partners locally, with law enforcement agencies, and see what of all of those are. So I'm just want to see. Okay, so yeah. So I think I've answered most of the things. I think the role of oversight start and where management start is an important part of how we clarify roles. The e-locker system. So somebody asked, our colleague from Gooks asked, who decides where the e-locker system is? What was that from discontinued? And we know in the areas like Gook and in other areas, this affected the NPOs that had people to follow up people that is on HIV and TB. There's a big impact because 10 NPOs has been affected. That money has been discontinued. So the progress has been discontinued. When we spoke about the e-lockers, it is one of the things where the money for the e-lockers is disappeared because this was funded out of that same PEPFAR money that was used to give the additional NPOs and to HIV to the areas. I've learned that it's something like the e-locker is an important thing. And then the question that you asked is the right question. From what we have, how do we make e-lockers within our available resources available broadly and over more areas to say, who does it serve, who makes the decision? And we're very happy to have those conversations. Then just the last thing that I see that's not been addressed is, I think, the article and this is Muskiewicz, the committee on the West Coast has been filled. The reason for the delay was it was difficult to find the appropriate, so we had to advertise it twice and go back to do that. And the city with the Metro Chief Director, Dr. Perez, is back at work, and he is taking up his full role as the Chief Director Metro. So it does come to Christian's question. So what happens if we know that people are leaving? How are we advertising possibly that there's maximum continuity? That's definitely an important consideration. We do have instances where we've done interviews before, and it is a valid. We need to look at greater continuity and shortening acting periods for people, because the longer you act, the more it's at that place, because you need leadership for the person to be in charge. And we pride ourselves that we want full-time employees in the jobs to be able to do the job. Chairperson, I belong. I apologize. Thank you.
To be fair, I did promise that I'm going to have a follow-up, and I'm going to start on this side. And just to inform the House that based on what came out, I'm also going to make a comment at the end.
Yes. Thank you, Chairperson. Can I go?
It's now me.
For that, let's have another. If someone maybe explain what is the logic. In Tilbach, there's a fairly new building infrastructure. Is it that residents even see us? Why should we phone Booster? Now you can imagine for me, it's okay, I'm serious, I know it, ek weet dit. Maar die frustrasie van Tilbach, daar's iets in klein begin wat gebeur en hulle sien die ambulance Booster toe bel. Wat is die logika agter dit? Because alhoewel ons dit nie weet nie, mense is besig om kwaad te raak en gemeenskappe, daar broei goed binne gemeenskappe en ons as civil society kan net soveel doen om gemeenskappe kalm te hou. But I think government is creating the strategically to make people angry and at the end of the day, like the comrade said, iemand moet verantwoordelikheid daarvoor vat because it doesn't make sense seeing an ambulance but you still need to phone Worcester and wait for it for a couple of hours.
Linda?
Chair, I think the official doesn't answer the question I was asking. The home-based care is under the NPOs or the NGOs. The department, what the major, they're supposed to also to intervene in terms of the development. Also, what is the requirements in terms of to create a funding or a funding, and also part of the funding is part of the trainings, and in terms of the opportunity where my member of unit in home-based care is working for 5 years in these NGOs, but in future I want to see in the hospital, Kalbrema, in Tigerberg, supposed to have a chain where you can develop other unemployment in the area because they do the great job with the community.
Mama Wase Gooks?
Voice and say, no, see, are you fighting with me? It's my voice. We are not here to fight. I'm glad that you really see a passion because we are all health activists, né? Because of the background, because of the situation, because of our past. So we give our time so that we can better our communities. We don't even care. The health committee in our agenda, if you can see our minutes of last meeting, those new health committees that have joined us, they nag about the stipend, and yes, there must be a stipend. But we are not putting that in front because at the end of the day, we are checking the people that are dying. Meanwhile, waiting for ambulances. Meanwhile, we are talking about stock out. Meanwhile, we are talking about those staff that are relocating that they are not replaced in our clinic. We had a partnership just recently with University of Stellenbosch. We were sitting there in my chair and check how many students are learning to be a doctor and to be a what. But where is the deployment of these people? Are all these people running to overseas and go service there? How many of them are graduating? Why always we've been talking 20 years back about shortage of staff. Can't even today we are talking the same language. I think what you are saying now, let us try to be close to each other because we are in the same tune. We want to service the community. We want the services that must be rendered to community. We want to check the issues of budget. Why every time we must talk about budget cuts? Why there is a budget cut issue? You understand? Meanwhile, services are not rendered in our communities. So I think the way forward that you are coming with is the better one if it's going to be implemented, because that's the main thing. Talking about these things, nice and good, reports, black and white, but when it comes to practicality, it's not happening. I would love that you keep your words and see that we are interactive to see how can we better services for our community. That's only interest of us. Thank you.
Damaris?
Thank you, Chairperson. The MEC, I mean, if I listen to my colleagues, it seems as if the current MEC is far removed from us. And I can echo their sentiment because I asked for an engagement with the MEC around the statutory bodies in the province. I know it worked. I know because I was there. up and until 2010, this province had the strongest community participation that you could ever have. In every district, even in the metro, there were plenaries held where the department came to account. The MEC's office were open to community engagement. Now you must give your CV to engage the MEC. Where does that come from? She's a public figure. We cannot have gatekeepers because I think I'm more on the ground than the MEC. The reality is, we're not asking the MEC to create wonders. I'm not asking the MEC to endorse us. We're done with that. The Portfolio Committee, the legislative body of the Constitution, which is this Portfolio Committee, needs to come out with a clear outcome on community governance within the Department of Health. It is a constitutional obligation. It is part of the act that they established in 2016. We almost how many years down the line? Community members don't call the MEC because they don't know her, so they call Damaris. I don't call her because I don't know where to get her. So I call Dr. Kluter. If Dr. Kluter can't answer me,
Point of order.
he sends somebody else. But the reality is we are fed up.
Order, Chair.
Sorry, Damaris, point of order.
Chairperson, thank you very much. I think we could engage each other this morning with the utmost respect. And nobody in this room dismisses the challenges that communities face out there and also the challenges that the department encounter. But I think we are threading very close to, touching on someone's personal integrity in that sense. This is about the review of this report. Can you please maintain the order, Chair?
Sorry. All right. Everybody will get a chance. Sorry. Okay. HOD.
So, Chair, I think some of those comments are quite unfair. I think Ms. Kivitz serves on the Civil Society Forum with senior management of the department, where she's able to view views of many communities on the Civil Society Forum, on which I'm briefed regularly. She's also at every single private sector think tank meeting as an engaged community member. So we have made sure, and I have made sure, that she's very much involved in the work of the department, from the private sector to civil society. And so I think that those comments were a little unfair. Furthermore, I'm engaging every day. I've crisscrossed this province and I continue to do that so that I can understand the issues and to understand from the strategy and policy realm from which is my responsibility to do, so that we can try and take the department to new levels and improve our service delivery. And you will start to see some of these interventions coming through in the new financial year, now that I've had an opportunity to have a look at what's happening in the policy and strategic realms. Thank you.
HOD, and then I'll respond.
Yep. So thank you. So let me respond firstly to Nosi. So Nosi, I think you use a very important term, and it really dawned on me when you were talking there. Because I believe that all the community activists that are here and the structures you there, you have it at heart of you. You care for the people that you serve, and you do it selflessly, and that recognition must be recognized. And I like the term that you use, that you play the role of a fire brigade, because invariably, I think, Chairperson, similar to what you said at the last quarterly meeting, many community members that are here are actually caught between a community member that is feeling the real experience of not being heard and their needs not being met. So there's a lot of community members that get then caught up between this is a person that needs something and you have a link with the service. So we need to recognize that our community structures and individuals play an important role about almost bridging and mediating between us must show the respect for that role. So thank you from that perspective. What I do like about is if we have those conversations, and you're always saying, just come have a conversation, let's find those local solutions and find one another, which I really like because that is the spirit in which we must take these things forward. Naomi, just in terms of what you were saying, I fully understand that because if I was living across a ambulance a station and I see an ambulance standing parked, but I use the call center number, and then the person said to me, okay, we will make sure that there's deployment, and then somebody will wait. And then the person says, but I see the ambulance there, somebody must just jump in the ambulance and come to my place. The system that we have done is actually the system of call and dispatch. That person that takes the call, they might be sitting in Worcester, but they have where they're sitting, they have all the active ambulances. There's a difference between a parked ambulance and an active ambulance, and that's why we say we don't want fancy conversation in books. We want to explain to you the difference between operational ambulance and an ambulance that's parked. Just because ambulance is parked nearby doesn't mean that ambulance is operational that day. Because to be operational, you need 3 or 4 people and all of those. But that's the kind of detail that we need to talk through to be explaining to you why is there a dispatch system? Why are we taking the calls? What are the things and how do we actually deal with all of this? But I completely understand the frustration and I understand how in communication it's difficult to explain that to somebody because you need to actually be able to say that's the logic that lies behind it. And then I think sir, I appreciate that you clarified the question about somebody being a community health worker, being in a hospital, being in Kolbrema. I appreciate it from the point of view that there's career pathing and skills development for a community health worker. And therefore, one of the big strategies that we do have is when community health workers are employed, that it must be clear that a community health worker has options for skills development. I mean, we do have stories of community health workers being professional nurses. We have stories of community health workers becoming pharmacy assistants. So it is important, again, that we sit with you and we explain to you that pathway, what the avenues are. And as the chairperson says, we will go to a nursing graduation and we see actually one of the nurses qualified that this person started out as a community health worker, enrolled into nursing, and 3 years later she's now a nurse. But it's important that we actually explain to you that there is a pathway and it must be clear to everyone what that pathway is and how it is actually utilized. And then just to Ms. Kivitz, the issue about the statutory body functionality, right, and the engagement. So I was there with Ms. Kivitz prior to 2010. And part of the issue was we had a system. It was called the Metro Health Forum. The issue was that we had that system, and Mr. Lindos, all of you that were part of that system, it comes from an older system where there was a commitment to move towards the role and respecting what community structures do. What followed was, and that was the lag, was the formalization of the legislation and the regulatory framework to formalize that. Now, I take the point that in formalization of getting the statutory and getting the legislation and all of those, it's important for us to reflect with the history that's there. What works well in terms of trust, getting people together. There's a lot of lessons of what we did before 2010 that we can draw upon to build community trust. Because if we do this in this review of this legislative process and part of this roadshow, there's lots to be learned about what we can build. The whole thing is, let's just find a way of working together. Let's find a way of being collegial. Let's find a way of being civil with one another. Let's find a way of respecting everyone's role and expecting and respecting every person's dignity and their person. So that's just an appeal from us. Thank you, Chairperson.
Thank you, Shudi. I see the hand at the back, but I need to say this. I have a responsibility as the chairperson to maintain a decorum in the House. And I did indicate that I will make a comment after everything. But Mr. Swabek, I see your hand is burning, and I want to warn you in advance. I'm not going to allow a tit for tat, and I'm going to close it off with you so that I can give my closing remarks on what I've just experienced. Mr. Swabek.
Thank you, Chair, and respectful, what's the name, to everybody. Something that I've been thinking about on a sideline to Dr. Kluti and to the MEC. Having recently attended a colloquium that was all the provinces with Noe and a couple of others that are here. One of the biggest frustrations we have, there's no communication from, when I say, don't get me wrong on the communication side, but what about appointing somebody within your directorate office that actually deals with the civil society issues and have a direct line? Because as far as it goes up to the CLO, the community liaison officer and the substructure, and then it seems to get lost. And it becomes the headless chicken. Maybe if there could be, can I call it a head CLO that then disseminates everything to the rest of the CLOs, or find some system, like you just said. Let's try and find a way forward. Thank you.
Actually, I'll leave that in your closing remarks. Now, let me make my closing remarks in terms of the outcomes of our engagements with the members of the public. Now, to the members of the committee, for your benefit, I also take responsibility for the frustrations which came out. And I want to put it on record for those who are working with the names that I will mention now, so that everybody can know what is happening behind the scenes. The Maras and Naomi, they are in communication with me. Every time they have something, they inform me. Now, I'm taking the responsibility and I'm taking the blame, Minister. I probably took too long for embarking on what I think is best for both of us. And as an example, why I believe I took too long, Member Kaiser Philander had a project earlier, sometime this year, and we were talking about it as chairpersons, and we probably didn't say it to you, member. Your program you had with interaction with all stakeholders across the province, it was the best thing that I've ever experienced. And in my mind, I had that in mind, Minister, that we should do something similar. And that is based on the outcomes of that quarterly report that we had there. Let's discuss the do's and don'ts. Let's know who's supposed to do what and what not to do, etc. So I take the blame. I really took too long. I did not come back to you on that, Minister, because I'm thinking the program is always too full. We must find slots, etc. I owe Witzenberg a visit. I owe everybody a visit. And I did promise we're going to visit as a committee. And even Nomonde, as the PO, has always been saying to me, it worked, it worked, it worked. What Member Kaiser Philander, came up with. So I put it here and I want the committee to hold me to that, Nomonde, in the next year, because it's their time of the year. We're closing off and it's just their time of the year. That we should make provision in the program next year, Member Vogel, that we do have this engagement. Like, for instance, nothing stopped us from having an IDP engagement where we just have tea and coffee and we talk. Nothing stops us. And then, Minister, out of those discussions, we will think, we're no, I was, oh my goodness, you're going to the area where I was told, please come, and there you go, and we didn't make plans. So I'm exposing you as well to that, and I want to apologize. I want to apologize for that, but going forward, I do think where let it happen. Uchumama was let's make it happen, and what we can do, we'll do. What we cannot do, as Naomi is saying, so that they can tell the people it can't happen this year, it will happen that year, etc., etc. So I'm going to close it off on that sense, and Minister and HOD, make your closing remarks, and after your closing remarks, everybody is welcome to join us for a brunch. Our brunch is no more breakfast and whatever is our brunch. And join us there for brunch. And members, I know I'm with you. When the HOD and the minister done with inputs, can we just sit for 2 minutes and get the people in the lounge? Then at least I'll be cooled by then. Closing remarks, Minister.
Thank you very much, Chair. Thanks to the committee for holding this statutory engagement on our annual report, and to the members of the public that have joined us this morning and have made their views clear, and we have heard what they have said, and we will be taking that back into our work into the new financial year. As we reflected on today, the 24-25 financial year was a difficult one that required both resilience and resolve. It's a year where we felt the hardest impacts of the funding cuts and the austerity measures in the system, but we were able to keep the healthcare system stable. And you will see when we come to brief you in the new year how we will emerge from this difficult year into a much better place in the coming financial year. I would like to thank the committee for the oversight during the course of the year. Thank you for visiting our facilities. Thank you for calling us to brief you on some pressing matters. I'd also like to thank the HOD and the senior management, as well as every one of our 31,000 employees, for the hard work that they put in every single day. I'd similarly like to thank all our partners from civil society, from academia, from the private sector, from the NGO sector. Because health, after all, is a team sport, and we can't do it alone. And so we're very grateful for all the support and working together that we were able to achieve during these tough times. Thank you.
Thank you, Minister. HOD.
Thank you, Chairperson. So you did say that I can respond to Christian in the last part. So I think it is a good idea that we need to look at channels of communication. I think just having a structural response to, okay, there's a person, it's not necessarily going to improve. What is the message? How often does it have to be communicated? Why does it have to be communicated? And how does it get to the people that need it? Part of building trust is having open channels of communication. So I think it's important that we do build this into this process. I just also like the minister. I first want to thank the minister. So I must say to you, as a department, we started the last year of this 5-year cycle. The minister came in the middle of that cycle. So she joined us and inherited this 5-year cycle. So the closure of the report that we've actually put in front of you is how she has seamlessly come in to guide us and work with us to see out this 5-year process so that we can start a new journey of 5 years together with her in terms of this. So actually this year under review, you probably came in 9 months of it or 8 months of this year and finding a feet and starting processes. The year that's starting now, so the next year under review will be the first year of the minister's actual 5-year term, concluding the previous year. And thank you, Minister, for your guidance. And thank you for allowing us to be able to do what we need to do, which is actually function in the way that we can. So thank you for that. So for the committee chairperson, to yourself and the committee, I think we did say this at the last meeting, at the quarterly meeting, to make this a interaction where we can build trust. And we did say to you, we repeated the 3 things, and I'll repeat it again, because that's what the Auditor General told us. If you have a problem and you show us a mistake, and you show us this is where you're coming short, we own it. We'll tell you this is what we think we're going to do about it. You check and say, have you done it? And you can come back. You can then judge whether you think we are credible and we stand for our word. That's the spirit within which we want to do that. And that's why those engagements become important. And then to the members of the public, I did say it and I will say it again. People making an effort to be here, means that they have community at heart. That for me is the fundamental. I understand the frustrations that you've said. I also know people personally in the group of people that are here that also communicates with me personally. And I know a lot of people have done this for many years, and I know how passionate are about what they do. I think the big thing that we must do out of this is take hands, walk, build a situation of trust and mutual respect, because only through that we can achieve wonderful things. And I'll be remiss to say that there's many people here in these benches by now that's been quietly sitting where some of them spoke. So I apologize to my colleagues, to the ones that just listened for the last 3 hours and 4 hours. But I must say to you, as an accounting officer, starting in 2020, my contract being extended under the watch of the minister for another 5 years, I couldn't have asked for a better team of people to be part of. I am merely just a member of the team. I mean, they know that. I'm just a member of the team. Many of the times I speak here, they roll their eyes quietly behind their back. But they are an incredible group of people that are incredibly committed. And that's why I say, Naomi and Nosi, what I see in you, I see in the people that sit behind me. I've yet to meet a manager in our department that does not have the care of the community at heart. And that's why I think there's synergy for what we can do. So thank you so much, Chairperson.
Thank you, HOD. HOD, let me tell you what I saw when you and the minister would respond, because I'm having a bird's eye view. And every time you guys responded, I could see the others also giving answers, you know, so, and yeah, with the eyes and the body language and the nodding. In my culture, we have a saying that says that inyati ibuzwa kwabaphambili. And people of my culture in here would know what I'm saying, but I'm going to try to translate it, but it's always difficult to translate a core traditional thing. But it means that when you're in a setup like this, and when people who have walked the walk before you, you listen to that, and there are people in here, members of this committee, who have walked the walk before me, and I do take that into account, and I want to say thank you very much for that. I'm learning as I was sitting here, and I've learned not to wait too long, and it just came out, I waited too long. It's something that I've learned. And now I'm going to give over to a member who has also walked the walk before me. She's my senior in politics. She's my senior in experience. She's my senior in position in the party. Over to you, Member Van Minen. Can you do your seniority thing?
Not too sure I like being described as senior in all those particular respects. I just want to say thank you from the committee side, from the standing committee. Thank you very, very much to the HOD, to the minister, to the senior officials here today, and to the entire department. We really do appreciate it. We know how hard everybody works during the course of the year, the amount of work that goes into the annual report, and then the amount of work that goes into preparing this meeting. And I really appreciate that. Thank you to the public who made the effort to be here. Thank you for engaging. It's vitally important that we have a compact with civil society and that continues. And to the committee, thank you very much for all the input you've got here. Thank you very much. It's greatly appreciated.
Thank you, Member Van Minen. And folks, once again, thank you very much. And then we'll meet you in the members' lounge for breakfast and for lunch. Thank you very much. Members, just another 2 minutes.
Member Vogel.
Members, as it Michaels, Michaels. Member Full, you may continue outside. Don't put fuel on the fire.
Get the last.
Thank you very much. In long engagement, I know, and I want to apologize for not giving you the deserved breaks in between, but I just thought maybe I'll try something new, but I've learned out of what I've tried. It's not going forward. We need to take our breaks. Members, any other points that you guys think that we should note going forward? Member van Minnen?
It's not a recommendation as such, but it is a suggestion that we explore a way of putting the annual report out to the public in a way that is accessible, by which I mean either as an executive summary or an executive summary accompanied by a suitable infograph, something along those lines. So that members of the public, I mean, I can understand that trying to read a 300-page or 297-page document can be quite intimidating. I think if one can put out the salient points in a way that is far more accessible. The Children's Commissioner has made very good strides in that regard, the way she does the way the office does the media. I think that potentially would allow people, particularly in areas that are quite far from the city, to essentially understand the details more clearly than having to wade through an intimidating document. So I'm just going to leave that as a suggestion. I'm going to make it actually for all the standing committees. But I think it's something that we as the WCPP should certainly consider. Thank you.
Member Walters and Member Kaiser Philander.
Chair, I think what we see is a institution that operated in a particular way, probably for decades before the democratic change as well. I'm talking administratively. There's a particular way. It's applicable across the world. Governments do things in certain ways. At the same time, and I think it's very commendable, we are busy moving to a whole of society and a whole of government approach that's more horizontal, more accessible, more call it engaging with the public. So I think in a sense, it's time for a rethink of how we actually get public participation that I think we all want. We want to hear. I think there's valuable things that we hear. And also, incidentally, the part of politics I enjoy the most, not the committee meetings. The committee meetings is sometimes, just like I'm sure the public experiences it a bit, very technical and very, and I think that it's good for the system to have a public participation process. But I think there is a difficulty in people who want to express themselves, and we want people to express themselves, and they come to a committee meeting, and that committee meeting is not really about what they actually want to bring to our attention. And this, if you think about it, this is an annual report. We're going through a thick document, trying to remember all the notes that we made, let alone the public. You would have noticed in the meeting, I'm also guilty of it. I tend to find a way of asking something else, but referencing it to the document, but I'm actually interested in the document. So I think we need a rethink. I don't think this committee can solve it. Perhaps my committee can look at it. I'm also not sure whether it's the right committee there, but I think we should have a chat about it and it's not passive consultation. How do we get the public how to do things better? And you know, that things like not entirely in this. Perhaps our committee should. I think there should be a further discussion there. I think it should involve all the political parties as well. I would then the other this is originally why I put my hand up. There was a proposal there for I think get a more opportune time with the quarterly reports that there should be a public stakeholder engagement in the around this portfolio. And I think that is something that we should perhaps put in as a committee resolution, that we would like to engage with that as well and beyond that as well.
Kaiser Philander style. Member Kaiser Philander.
Baie dankie, voorsitter. Thank you, Chairperson. Based on the input provided by Member van Minnen, I think it's quite important that although there might not have been that much community participation in other committees, that doesn't mean that people actually understand the contents and also in terms of what we are trying to achieve by making the public involved in the processes of Parliament. So I would like us to extend the recommendation in that regard, Chairperson, so that it can actually, and I don't think there's a Chairperson that will object to that, so that we actually establish that rule that when we come to these processes, that we do have that information available to each and every committee, that although we don't share it to those in attendance, we have constituents which we can share it far and wide in order for them to understand exactly what the process entails and what is happening within the said portfolio. So I'm sure Ms. Jamke will be able to contextualize and frame that, but I think that should be something that should run across all portfolio committees. Thank you, Chair. For standing committee.
Baie dankie, Chair. Chair, I think in my during the questions I asked for some information in writing. I'm not sure if Namone noted that because the department didn't answer. It was the issue of the employment equity.
I think it was, I remember that 646 saying
141.
141.
And
yeah.
There were actually two. I can let you rather.
Yeah, it's like the equity and how the department have grown since 2020 to now.
Yes.
Yeah. Whether it has grown or whether it has shrunk.
And in terms of the cases.
Yeah.
Yeah, that was the three.
The cases, the example of the matters, yeah.
Yeah. And then lastly, I agree with our colleagues in terms of the way forward and how we can get the community involvement. Though sponsors sometimes so far, the department is doing a good job. But die mense experience op die grond, hulle verstaan nie die hele sê. Because sometimes when the to-do is explaining, and I like, what about the old person? There's so, and it kan nie gesolf word nie. En hier is die platform, jy die minister in front of you, you have the HOD. So hulle kom uit, hulle borrel uit. They are using this platform because in the absence of or let's say us as leaders, that's what is going to happen. So I love the initiative by saying that in Davao, if you put whatever we call it, where you have this different stakeholders, same as what social development were doing. If we have the same approach where we invite all those stakeholders and that type of platform where they can engage and reports to school. So then when you get this stage, these people have an understanding what. Therefore, I will ask to be excused. Yeah? I'm part of the interview panel, and
Because of that, Member Van Proe? Member Van, because of that, the meeting is adjourned. Thank you.